Hello, check. Hello.
Before we start this program, I humbly request everyone here, please put your phones on silent mode. And if at all you need to take a call, please do it outside the hall. Thank you. Our worthy director, Dr. William Bhatti, today's chief orator, Dr. Bashi V. Velayudhan, Vice Principal, Dr. Ashish Varghese, Punjab Medical Council member, Dr. Karamveer Goyal, Organizing Secretary and Head of the Department of General Surgery, Dr. Parvez David Huq, Medical Superintendent and Head of Cardiothoracic Surgery, and the Organizing Chairman of this oration, Dr. Alan Joseph, a galaxy of eminent cardiac surgeons and cardiologists, faculty and students. A very good morning to all of you. It is my immense pleasure to extend a warm welcome to all of you for the second Dr. Forrest Carey Eggleston Memorial Oration 2022 on exploring advancement and innovations in aortic surgery.
Now, we would like to acknowledge the presence of respected dignitaries with the fragrance of our love and respect. I would like to call upon Ms. Avika to present a bouquet of flowers to our worthy director, Dr. William Bhatti, and accompany him to the dais. I request Ms. Srishti to present a bouquet of flowers to respected Vice Principal, Dr. Ashish Varghese, and accompany him to the dais. I request Dr. Megha to present a bouquet of flowers to Dr. Bashi V. Velayudhan, the Chief Orator of the day, and accompany him to the dais. I request Dr. Susha to present a bouquet of flowers to Dr. Navneet Kumar Chaudhary, Secretary, Dr. F.C. EGGLESTON CMC Ludhiana Trust, and accompany him to the dais. I request Dr. Megha to present a bouquet of flowers to Dr. Karamveer Goyal, Punjab Medical Council member, and accompany him to the dais. I would like to call Dr. Shreya to present a bouquet of flowers to Dr. Parvez David Huq, Organizing Secretary, Professor and Head, Department of General Surgery, and accompany him to the dais.
I request Dr. Subha to present a bouquet of flowers to Dr. Santosh Matthew, our proud alumni and Chief Cardiac Surgeon, Ahalya Hospital, UAE. I request Dr. Tanya to present a bouquet of flowers to Dr. Rajiv Gupta, Professor and Head, Hero DMC, and also Secretary, North Zone of Cardiac Thoracic Surgeons. I request Dr. Susha to present a bouquet of flowers to Dr. Yash Paul Sharma, Professor and Head, Department of Cardiology, PGI Chandigarh. Now I request Dr. Shreya to present a bouquet of flowers to Dr. Satish Matthew, He is also our very own alumnus and Chief Cardiac Surgeon, Kailash Heart Institute, Noida. We also acknowledge the presence of Mrs. Setu Bashi, ma'am. So, yeah, sorry. I request Ms. Diksha to present a bouquet of flowers to Madam Kate Whitecomb, US Board and Trust Member. Thank you, ma'am, for joining us today. I request Dr. Sarita to present a bouquet to Dr. Melki, sir, Deputy MS and the HOD of Anesthesia. I request Ms. Aishwarya to present a bouquet of flowers to Medical Superintendent and Organizing Chairman, Dr. Alan Joseph, and accompany him to the dais.
I request Dr. Subha to present a bouquet of flowers to Dr. Prem Nath Mahajan, Dr. FC Eggleston Trust Member. I request Ms. Avika to present a bouquet of flowers to Dr. Satish Chandra, Dr. FC Eggleston Trust Member. So I'm very sorry, Dr. Sirish Chandra. Really sorry, sir. I request Ms. Meena to present a bouquet of flowers to Dr. Gurdeep Singh Sidhu, Dr. FC Eggleston Trust Member. Dr. F.C. Eggleston, respectfully addressed as the boss. This name can only be written with reverence among the apostles of goodwill who traveled all the way from West to Asia and Africa, carrying the concept of compassionate care to the masses. He took up the challenge and took over as founder and head of the Department of Surgery at CMC Ludhiana on 1st October 1955. And pioneered a modified American residency program in surgery. Dr. Eggleston also served as the director of CMC Ludhiana from 1982 to 1986. Over a period of 3 decades, from 1954 to 1986, Dr. Eggleston trained more than 100 surgeons. He was a great teacher, a source of perpetual inspiration to his pupils in patient care. His perseverance, hard work, and dedication towards surgery not only nurtured excellent surgeons, but also put the Department of Surgery of CMC on the map of the world. At the age of 96, he left for his eternal abode on 7th November 2016. On June 11, 2018, the Dr. F.C. Eggleston CMC Ludhiana Trust was established by his students and the surgeons. The aim of the trust is continuing medical education in surgery and other fields of medicine.
Now I request the choir for the invocation song.
You are my strength when I am weak. You are the treasure that I seek. You are my all in all. See seeking you as a precious jewel. Lord, to give up, I'd be a fool. You are my all in all. Jesus, Lamb of God, worthy is your name. Jesus, Lamb of God, worthy is your name. Taking my sins, my cross, my shame, rising again, I bless your name. You are my all in all. When I fall down, you pick me up. When I am dry, you fill my cup. You are my all in all. Jesus, Lamb of God, worthy is your name. Jesus, Lamb of God, worthy is your name. सारी सृष्टि के मालिक तुम ही हो, सारी सृष्टि के रक्षक तुम ही हो। करते हैं तुझको सादर प्रणाम, गाते हैं तेरी ही गुणगान। हालेलुया, 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 आमीन। सारी सृष्टि को तेरा सहारा, सारे संकट से हमको बचाना। तेरे हाथों में जीवन हमारा है, अपनी राह पर हमको चलाना। हालेलुया, 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 आमीन।
Lord bless you and keep you. Make his face shine upon you and be gracious to you. Lord, turn his face toward you and give you peace. Amen. Amen. Amen.
upon you and 1,000 generations, and your family, and your children, and the children, and the children. May His presence go before you, and behind you, and beside you, all around you, and within you. He is with you, He is with you, in the morning, in the evening, in your coming and your going, in your weeping and rejoicing. He is for you, He is for you. Amen. 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 Amen.
Peter from the Fellowship Department to lead us with a word of prayer.
I will read from 2 Timothy chapter 2 and verse 20. In a large house there are utensils, and not only of gold and silver, but also of wood and clay, some for special use, some for ordinary. All who cleanse themselves of the things I have mentioned will become special utensils, dedicated and useful to the owner of house, ready for every good work. We'll just give ourselves in God's hand for a moment. It's a beautiful morning. Let's start with God's presence in our life. We all who are here are God's utensils, especially called to do His good works. So in the morning, start with the dedication and prayer. Heavenly gracious Father, thank you, Lord, for this beautiful morning. Thank you for bringing all of us together in your presence, Lord. Lord, we are so thankful in our lives for giving us the opportunities, moments, and above all people, so that we be strengthened and blessed and prepared to serve you, Lord. And we are so thankful for Christian Medical College and Hospital, Ludhiana, that you have prepared it till this point and led it to this point. And at this time, Lord, we are so thankful for the beautiful life and witness of Dr. F.C. EGGLESTON, such a wonderful surgeon, teacher, and also the administrator. Lord, we are so thankful for each and everything that you have did through him in our institution, and also the people and his students' lives. And today, Lord, we are here in his memory in this F.C. EGGLESTON Memorial Lectures, Lord. And Lord, we give Dr. F.C. EGGLESTON Memorial Trust in your hands. From the moment of his formation till this point, you have led them so wonderfully. In future also, Lord, let they keep on bringing forward the legacy which we have caught through the life of Boss. And at this time, Lord, we give each and every eminent speakers and cordialists who are here, Lord. Thank you for the work that they are doing in all over the world, and the wisdom and the knowledge which they are going to partake with us. Let it be a blessing for all the learners. And we give the whole day in your hands, Lord. Let your Spirit guide and lead us and we be guarded and protected by your angels. In your holy and precious name, we pray. Amen. Thank you.
Now I request the dignitaries on the dais and the speakers for today, Dr. Santosh Matthew, Dr. Rajiv Gupta, Dr. Yash Paul Sharma, Dr. Satish Matthew, to please come forward for the lamp lighting ceremony. Can we have a round of applause, please? Now I request Dr. Navneet Kumar Chaudhary, Secretary, Dr. F.C. EGGLESTON, CMC Ludhiana Trust, Senior Consultant, SPS Hospital Ludhiana, and a former resident of Dr. F.C. EGGLESTON, to please come forward and kindly deliver the welcome address.
Honorable Chief Guest, Dr. V.V. Bhashi, Dr. William Butty, Director, Dr. Ashish Varghese, Vice Principal, Dr. Parvez Haq, Head of Surgery and Organizing Secretary, Dr. Alan Joseph, Medical Superintendent, Dr. Karamveer Goel, Member, Punjab Medical Council, members of Dr. F.C. EGGLESTON CMC Ludhiana Trust, Dr. Sirish Chandra, Dr. Gurdeep Singh Sidhu, Ms. Catherine Whitcomb from US, faculty for today's CME, including Dr. Santosh Mathew, Dr. Yashpal Sharma, Dr. Rajiv Gupta, and Dr. Satish Mathew, esteemed delegates, invited guests, students, ladies and gentlemen. I welcome you all for today's special event as we celebrate the life of Dr. Forrest Carey EGGLESTON, the founder of the surgery department at CMC Ludhiana. It's a great honor for me to say a few words about Dr. EGGLESTON. Dr. EGGLESTON graduated from Princeton University in 1942 and received his medical education from the Cornell University in New York in 1945. He did his residency in surgery from Columbia University and surgical resident training in thoracic surgery at Presbyterian Hospital, New York. He was a diplomate of American Board of Surgery, diplomate, American Board of Thoracic Surgery, and a fellow of American College of Surgeons. Dr. EGGLESTON was US Navy World War II veteran. Dr. and Mrs. Forrest EGGLESTON, along with their two small children, first arrived in India in December 1953 as Presbyterian missionaries from USA. Dr. EGGLESTON's first assignment in India was to head up to the TB sanatorium at Jubar in Kasauli Hills in Himachal Pradesh, about 200 kilometers from Ludhiana. While there, he was requested by Dr. Eileen Snow, then principal at CMC Ludhiana, to help her start the Department of Surgery at CMC. Dr. EGGLESTON took up the challenge and joined CMC as head of surgery on 1st October 1955. He had a fiercely scientific outlook, and one of the first things he did was to establish the surgical research laboratory here, where animal experiments, especially those related to cardiovascular surgery, were performed routinely. Dr. EGGLESTON was the first person in North India to introduce the use of intravenous potassium, peritoneal dialysis, blood gas analysis, and acid-base analysis, and use of ventilators in the care of sick patients. He initiated a program to develop various surgical specialties like cardiothoracic, urology, pediatric surgery, plastic and microvascular surgery at CMC, and pioneered open heart surgery, the now common practice of having separate branch of surgery to deal with cancer patients, including concept of tumor board, was in fact his brainchild and first put into practice by him in CMC in 70s. Dr. EGGLESTON also served as director of the hospital from 1982 to 1986. In span of over 3 decades, he taught more than 1,300 medical graduates and trained more than 100 surgeons who were spread all over the world as excellent surgeons carrying out the rich legacy of their boss. He was a great teacher who constantly encouraged his pupils to keep the well-being of their patients as their main motto. His training and dedication towards surgery not only nurtured excellent surgeons, but also put the surgery department of CMC on the world map. Dr. EGGLESTON was a man with a wide range of interests. He was a voracious reader. His library was extensive, and he lived intimately with his formidable collection of books. He was very fond of music, hunting, and sports. The cultural side of his nature was not only well known, but it spoke much of his well-grown personality, which complemented his unique leadership qualities. He was a Christian in truest sense and treated everyone equally and was fondly addressed by boss by everyone. The Christmas party of the department used to be fabulous and full of warmth. Much glamour to his efforts was aided by his devoted and understanding wife, Barbara EGGLESTON, who always lent her unflinching support. Mrs. Barbara EGGLESTON typed the thesis of all the surgical residents that boss supervised in his career, and that is a tremendous commitment. For more than 3 decades, the weekly journal club was held in the evening at their home, where she served tea and cakes to the residents each time. Starting an oration in his memory itself speaks of love and affection he enjoyed among his students, colleagues, and people he encountered. Dr. Eggleston retired in Mechanicsburg, Pennsylvania, USA. He cherished the spirit of CMC till he left for his eternal abode on 9th November 2016 at the age of 96. After Dr. Eggleston's death, Dr. Sarjeet Singh Gill from the Pioneer Batch and a renowned thoracic surgeon from US, along with alumni and surgeons trained by Dr. Eggleston, decided to create something special in Boss's memory. Dr. Gill has worked very closely with Boss in 50s and 60s at CMC. It is under his guidance that on June 11, 2018, Dr. F.C. Eggleston CMC Ludhiana Trust was established. The aim and objectives of the trust are to promote by various means medical education in India in the memory of Dr. Eggleston. To achieve these goals, the trust will recourse to some of the following methods depending on the availability and adequacy of the funds. To hold Dr. F.C. Eggleston Memorial Oration every year in a medical subject chosen by the trustees. To hold seminars or workshops preceding or following the oration on selected topics. To arrange visiting professorship or fellowships of short durations. And to organize other activities which would promote medical education as the trustees deem fit from time to time. On 23rd March 2019, the trust organized the first oration, and the speaker was renowned laparoscopic surgeon Dr. C. Parnivelu, founder president of the Association of Minimal Access Surgeons of India and former president of Association of Surgeons of India. We could not hold this function for 2 years because of COVID. Friends, we are indeed fortunate to have Dr. V.V. Bhashi, a world-renowned cardiothoracic surgeon from Chennai, delivering the second Dr. F.C. Eggleston Memorial Oration. This will be followed by a scientific program, and for that we have got a learned and talented and experienced faculty, deliberating on current issues in cardiac medicine and surgery. Keeping in line with the Eggleston's noble idea of sharing knowledge and experience without boundaries, the academic activities of the trust will be without a registration fees. Donations to the trust are welcome. The trust is grateful to the Christian Medical College Hospital Ludhiana for its very kind and generous support for fulfilling its motto of furtherance in medical education. Once again, I extend a warm welcome to all of you. Thank you very much.
Thank you, sir. Now, I would like to acknowledge the presence of Dr. V.K. Sharma, Dr. Ashwini Suri, Dr. Vikram Pal Singh, Dr. Arvind Kohli, and Dr. Kamal Negi. A round of applause for all these eminent cardiac surgeons. I request Dr. Megha to please present a bouquet of flowers to Dr. Karamveer Goyal, who is a respected PMC member who has taken time out from his busy schedule to join us for this oration. Thank you, Alan, sir.
We also acknowledge the presence of Mrs. Setu Bashi, ma'am. I would like to request Alan, sir, to please present a bouquet of flowers to ma'am.
Thank you so much, sir. I now would like to request respected Director Dr. William Bhatti to please come forward and address the audience.
Very good morning to all of you, especially to Dr. V.V. Bhashi, chief orator of today's oration. He is Director, ICAD SIMS Hospital, Chennai. Dr. Santosh Matthew, I had privilege to work under him as a resident. Dr. Rajiv Gupta, Dr. Yashpal Sharma, guest of honor, Professor and Head Cardiology, PGI, Chandigarh. Dr. Satish Matthew, thank you Satish for joining us. Other dignitaries on the dais, Dr. Karamveer Goyal from Punjab Medical Council, Dr. Alan Joseph, Medical Superintendent, and Professor and Head of Cardiothoracic Surgery, Dr. Parvez Haq, Dr. Navneet Chaudhary, he is a member trustee of FC EGGLESTON CMC Ludhiana Trust and secretary. Other trustee members, especially Dr. Mrs. Whitcomb, Catherine Whitcomb, all the way she has come for oration from USA. Dr. Srish Chandra, he is always with us, just a phone call away. Dr. Sidhu, and others, those who have joined us through Zoom link in USA. I am sure Dr. Sarjeet Singh Gill will be there, along with Dr. Elizabeth Paul. My colleagues, friends, staff and students, distinguished guests from Ludhiana and other part of India. On behalf of CMC Ludhiana, our management, I welcome you all for Dr. FC EGGLESTON oration. Much has been said about BOSS, and while Dr. Navneet was telling about Dr. EGGLESTON, I was thinking how Ma'am Barbara EGGLESTON was helpful to Sir while he was busy in surgical work. She was also contributing in nearby school as a manager of Ewing Christian School, where I was a student. And she was devoting her time and efforts for the education of children, not only in school, in department also. She was taking care of resident. So that shows as a family, they were fulfilling the call of missionary work with zeal and enthusiasm. I am not trained under Dr. EGGLESTON, but I had experience of all those who were trained under him. They were my teachers. So I could make out what kind of training they have received in surgery department of CMC Ludhiana. So that is the legacy which as a family they have left to fulfill the vision and mission which our founder had, Dr. Brown, to promote healing and education. Once again, I am grateful to all trustees for their vision to have an oration at least once a year where we can remember the work done by Dr. EGGLESTON, and I am sure it will inspire all of us to carry forward the vision and mission of our founder, Dr. Mary Brown. With that, I am sure this is an occasion where we will learn and we will share fond memories of our time spent in Department of Surgery, CMC Ludhiana. Thank you. God bless you.
Now I would like to request respected Vice Principal, Dr. Ashish Varghese, to please come on the dais and say a few words.
It is said that practice makes a man perfect. Does it hold true in medical sciences or a surgical specialty? If you look at the way medical literature is growing in the past, in 1950s it was 50 years, and so was the life expectancy. So if you see in the last, over a period of 50 years, the knowledge has been increasing exponentially. So to say that practice makes a doctor perfect is not true. How do you make or aim towards perfection? It's by attending meetings like this, where you hear stalwarts, professionals who are on the top of their specialty. At this point, I would like to welcome you all on behalf of Dr. Jairaj Pandian, who is our principal, and on behalf of the medical college, and I hope you all have a good learning teaching experience. Thank you.
Thank you, sir. Now I request Madam Kate Whitcomb, FC EGGLESTON Trust member, who has come all the way from USA, to please come on the stage and share a few words. Ma'am Kate Whitcomb.
Good morning. It is a great honor to be here at the second oration for the EGGLESTON Trust, and I'm very impressed by the list of presenters and the papers that you're going to hear today. I just want to share with you quickly that I am the executive director of the Ludhiana Christian Medical College Board, USA. We are your extension and partners in the US, raising money and investing it and sending it back here to Ludhiana for various projects that are needed by the hospital. I know all of those who are watching online, especially Dr. Gill and Dr. Paul and Dr. Sewa, but I want to tell you the members of our board. You will recognize some of the names. We have 14 members, and I will just read you their names. Dr. Harish Anand, Dr. Gurpal Buhler, Dr. Virginia Hall, Dr. Sewa Lega, Dr. Elizabeth Paul, Mrs. Sue Sareen, Dr. Feroz Yusufji, Dr. Mariam Chako, Dr. Brian Uman, Dr. Roy Thomas, Dr. Harvinder Bedi, Reverend Tom Salzgiver, Dr. Dorothy Barbo, Reverend Max Marble, and Dr. Ruth Yoder Dial. They all send you their greetings and their blessings. They keep you in their prayers, as I do. Congratulations on the second oration. I know it's been very frustrating to have 2 years of pandemic when this could not occur, and I'm very grateful I was able to be here today and bring you greetings. God bless.
Thank you, ma'am. I now request respected Punjab Medical Council member, Dr. Karamveer Goyal, who has taken time out from his busy schedule to please come and present a few words.
A very good morning to all. Chief guest of today's function, Dr. Vashi, Director CMC, Dr. William, other dignitaries on the dais, esteemed faculty members, doctors, delegates, residents, staff, and students. I bring greetings to you all from Punjab Medical Council on this very important day of FC EGGLESTON Memorial Oration at CMC Ludhiana. And as already declared, I announce 4 credit hours for today's workshop. As always, CMC has been in the forefront of the good academic activities in Northern India, and no institution comes near it, parallel to CMC. And today's workshop commemoration is one part of it. I'm really glad that the FC EGGLESTON Memorial Trust, in association with the CMC, is surging ahead in further activities of surgical innovations and exploring new techniques in aortic surgery. My best wishes from PMC. Just in the lighter vein, I just wonder, when the surgeons are there, what do they think about the physicians? I'm a physician. The other day I was just hearing the conversation between 2 people, 2 doctors, and they were just discussing about the future of his son. He said, okay, he's not very good, he's a mediocre person. I don't think he can be a good surgeon. He can be a physician and keep on writing prescriptions. So I don't know, how do you feel about the physicians when you are, having brainstorming sessions about new innovations and exploring new techniques in surgery and all. Anyway, Have a wonderful day. All the best from CMC. Thank you very much once again.
Thank you, sir. Moving on to the most awaited part of the morning, the second Dr. Forrest Carey Eggleston Memorial Oration, to be delivered by Dr. Bashi V. Velayudhan. So I request the members on the stage to please take their respective seats among the audience. Now I'd like to request, respected Medical Superintendent and Organizing Chairman, Dr. Alan Joseph, to please come forward and introduce the orator, Dr. Bashi V. Velayudhan, to the gathering.
A very warm welcome to all of you. It is my proud privilege to introduce today's orator for second Dr. F.C. Eggleston Memorial Oration, Dr. Bashi V. Velayudhan. Dr. Bashi V. Velayudhan is a senior consultant at SRM, Institute of Medical Sciences and Hospital, Chennai. He is the director of Institute for Cardiac and Advanced Aortic Disorders and adjunct professor at the Tamil Nadu Dr. MGR Medical University, Chennai. He is also the senior past president of the Indian Association of Cardiothoracic and Vascular Surgery. He did his MBBS from Medical College, Kottayam, MS General Surgery from Medical College and Hospital, Trivandrum, MCH in Cardiothoracic and Vascular Surgery from Christian Medical College and Vellore. Then he worked as a professor in CTVS department at CFC Vellore for 12 years. Thereafter, he worked in various prestigious institutions like Royal Adelaide Hospital, Australia for 3 years, as senior consultant at Institute of Cardiovascular Disease, Madras Medical Mission for 4 years, as chief cardiac surgeon and clinical director at Malar Heart Foundation, Malar Hospitals, Chennai for 6 years, and as chairman and chief surgeon at Center for Thoracic and Cardiovascular Care, Mayat Hospital, Chennai for 14 years. He has so far performed over 15,000 surgeries over a span of almost 4 decades. He is a pioneer in beating heart surgery and total arterial grafting for bypass surgery in India with a success rate of almost 99.5%. He is one of the most experienced surgeons in complex aortic aneurysm surgeries in India and has performed more than 1,500 aneurysm surgeries. This includes more than 400 aortic root replacements, 150 aortic arch replacements. He is specialist in complex reoperations for aortic aneurysms, coronary bypass valve surgeries. He has also performed almost 400 mitral valve repairs and 150 tricuspid valve procedures. He is also an expert in adult congenital surgeries, double valve replacement surgeries, carotid endarterectomies, pulmonary thromboendarterectomy, and heart transplants. He has published more than 100 articles in reputed national and international journals and has presented more than 200 papers in various national and international meetings. He is a fellow of American College of Surgeons and life member of Indian Association of Cardiothoracic and Vascular Surgery and Vascular Society of India. He is also a member of Association of Cardiothoracic Surgeons of Asia, Society of Thoracic Surgeons of USA, European Society of Cardiothoracic Surgeons. Sir has given lectures and orations, performed surgeries, live workshops, and participated CME programs in different teaching institutes of India and abroad. He was invited faculty thoracic aortic aneurysm in Bologna, Italy, 2007-2017, Australian Aortic Symposium in Melbourne, Australia, 2017, Cardiac Society of Nepal in Kathmandu, 2014-2017, Aortic Asia in Bangkok, 2016, Japanese Aortic Symposium in Tokyo, Japan, 2015, Aortic Symposium in Bali, Indonesia, 2015, Vascular Society of New Zealand, Hamilton, 2013, Aortic Symposium in Pattaya, Thailand, 2013, Vascular Society meeting Beijing, China, 2011, Fenestrated Endovascular Workshop, Singapore, 2010. In 2011, he received Lifetime Achievement Award from Tamil Nadu MGR Medical University. In 2013, he also received AKMG Association of Kerala Medical Graduate Dubai Chapter Lifetime Achievement Award and Indo-Australian Award for Meritorious Service. In 2017, he received by Tamil Nadu Medical Practitioner Limra Award for Eminent Medical Personality. It is an honor to have him with us for second Dr. F.C. Eggleston oration. I hereby invite him for the oration. And before that, we would like all the Dr. William Bhatti, Director, Dr. Navneet Chaudhary, Secretary of the Trust, and before delivering the oration, we want to facilitate him. And we call all the trust members also, Dr. Sidhu, Dr. Sirish Chandra, and Madam Catherine Whitcomb. So everybody can come forward to facilitate.
वो साइड में
I request our Chief Orator, Dr. Bashi V. Velayudhan, to please come and deliver his oration. Sir.
At the outset, I am short of words for the affection and the hospitality shown to me by all the members and the staff of CMC Hospital, Ludhiana. I am reminded about 42 years ago when I joined CMC sister institution, where I had the privilege to work for 12 years. And I owe my whole professional success to CMC Vellore, who has made me what I am today. So I'm extremely happy that I've been chosen for this oration of an eminent surgical personality in the northern part of India. And most of the things was talked about him by the introductory speech by Dr. Chaudhary. I'm thankful to Alan for inviting me. It was supposed to be done about 2 years ago. And my colleague, Mohan Varghese, we did MCH together. He was inviting me for ever since 1980 to come to visit Ludhiana. And I'm thankful to all of you for making this happen. Previous speaker has spoken about the physician and the surgeon, so I must read a few things about the surgery. Medicine is truly a fascinating, and being surgeon is an Olympus. Skillful fingers and sharp mind remove illness, reshape or replace organs in a constant battle. To be a surgeon, it is not enough to know anatomy and physiology. It is a long journey in which the difference between fear and cowardice is not always clear. Every good surgeon knows that surgery never ends at the last stitch and always leaves at least 2 scars, one in the patient and another in the surgeon. At last, we believe surgery is more than a pure science. It is an art, a complex art of temporary truths, and the only unchangeable truth we can have in surgery is the certainty that eventually everything will change. So be prepared, the future is now. And imparting knowledge is like a river flowing into an ocean. The more it flows, the more it fills. So that is the basic principle of teaching. I'm sure Dr. Eggleston has done to all those people who are sitting here. I'm sure, I must consider I am unfortunate not to have trained under him, even though I have trained with very eminent surgeons in CMC. And Mohan always used to talk about Dr. Eggleston, even though I have not worked with him. He has very often, every other day, something when he is doing, he always used to remind of Dr. Eggleston. So I'm very proud and happy and privileged to be here to give this oration. And I chose the topic of aortic dissection because, as you know, as the aging population is increasing in India, we used to wonder that, as a trainee, I've never seen aortic dissection in CMC. Very, very rare only because patients never used to reach the hospital and the lifespan of the patients were much less those days. But now we see a large amount of scope in aortic surgery. And the surgeons in the future will have plenty of work and should be prepared to tackle this. So with this, I will start my talk on aortic dissection. Current management strategies. So no talk about aortic surgery is complete till I start with the father of aortic surgery, Michael DeBakey, who on 2005, at the age of 97, suffered an aortic dissection, the condition that he pioneered procedure he designated to treat. And there was a lot of discussion whether to treat him. He himself initially said, I don't want to get operated. But after that, he underwent surgery and he had a successful outcome. He could not complete his 100th birthday, but 2 months before his 100th birthday, he passed away. And he is considered the father of aortic surgery in the world. Now, before I start about dissection, just a few words about the anatomy. Of course, all of you know about this, the different layers of aorta, the intima, the media, and the adventitia. And the pathophysiology, as you know, it starts in the intima. A tear in the intima is the entry point in the aorta. It can be anywhere. It can be the ascending aorta or descending aorta or any other part of the aorta. So from that, the blood distance, it spreads to the other part. It separates the layers of the aorta. And depending upon the luck of the patient, it can start from the aortic root to anywhere in the descending thoracic aorta up to the bifurcation. So this animation shows how it happens. You can see the 3 layers. And then the intima breaks, blood enters into the media. You can see the tear in the intima, that is the blood, that is the adventitia, that is the media. So it extends, keep on extending. This is the ascending aortic entry. It can have an entrance in the descending aorta. Now, DeBakey's classification still holds, is followed by many centers, and other is the Stanford classification, where DeBakey's classification, the entry point is in the ascending aorta extending beyond the arch, and type 2 is ascending aorta only, type 2A descending aorta, type 3B descending aorta extending below the diaphragm. Type A dissection in Stanford classification ascending aorta, type B is descending aorta. So this is there's another classification depending upon the duration of the disease. That is the normal aorta you can see, acute in when the patient present within 2 weeks, and chronic when it is more than 90 days. And if it is more than 90 days, you can see it is almost, the blood clots may be there in the aorta, it is not as lethal if the patient survives. The risk factor of aortic dissection, bicuspid aortic valve, atherosclerosis, connective tissue disorders. People who have known aneurysm in the family are prone to get about at least 15% more chances to get aneurysm. Aortoarthritis, the drugs, hypertension, pregnancy, after cardiac surgery, after open heart surgery, sometimes aorta can dissect in the cannulation sites or coronary anastomotic areas. Frequency of primary tear, as you can see, about 60% of the tear occurs in the ascending aorta and 6% in descending, and about multiple tears in about 8%. In type A. Type B, it is occurs, majority of the tear occurs in the descending thoracic aorta. Now, clinical features depends upon where the aortic dissection extends. Most of the patients who have tearing back pain. There are instances, many instances where patients were given treatment for acute myocardial infarction with the thrombolysis, because sometimes ECG changes may be there, or patients may have dissection in the coronary arteries mimicking myocardial infarction. I had, at least in my experience, 10 to 15 cases where patients were thrombolyzed with suspected myocardial infarction. Then surgery becomes very difficult. Life-threatening complications, as you can see, is aortic insufficiencies. Some patients, the aortic valve may tear, and sometimes they can die suddenly. Occlusion of the coronary artery, if it occurs in the left main, it can produce arrhythmia, sudden death. Rupture also produces sudden death, tamponade, ischemia of the viscera, and cerebrovascular accidents. So when left untreated, so you saw the problems which can happen. 33% of the patients die in the first 24 hours, and 50% die in 48 hours. The 2-week mortality approaches 75% in patients with undiagnosed aortic dissections. That means it's so serious. And this X-ray, of course, just for theoretical thing, I put it, it is not of much value nowadays. There are much better investigations like the CT scan. You can see a 64-slice CT aortogram has revolutionized the treatment of aortic dissection, because now in our hospital, anybody with suspected chest pain, before doing coronary angiogram, we do a CT, because make sure we are not dealing with an aortic dissection. And also, peripheral centers are having more aortic, for screening centers, scan centers are everywhere. So more and more cases are picked up nowadays because of the simple investigation. That is, even a plain CT can tell you, undiagnosed pain, aortic dissection. Of course, sometimes they present with malperfusion syndromes. So then transesophageal echo is another simple investigation, which if it is most of the cardiac advanced centers will be available. You can see the flap moving there. The aortic flap in the ascending aorta is totally dissected. And the most important thing is a good aortic team. Of course, it may not be available in most centers. One of the problems is taking the patient to a higher center, and coordination between a team, aortic team I call. It's important, the cardiac surgeon, the clinical cardiologist, radiologist. Of course, a good diagnostic radiologist is very important to diagnose the problem. And if you have got a good interventional radiologist, like a laser precision, we can diagnose where is the entry, because it's very important to treat the patient according to the site of entry. So decision making in any other field of sports or anything, it is so important. What is to be done for the patient, when the patient to be operated, and how to manage post-operatively, and how to do the follow-up. So management strategy in type A aortic dissection, 100% it is surgery. Chronic type A also is surgical treatment. Type B, uncomplicated, is medical treatment. Acute type B complicated is surgical or endovascular, which I will come later. So management of type A dissection, approach in the emergency room is very important, because most of the time the junior doctor will see the patient with suspected aortic dissection, may not be aware of the blood pressure of the patient. It is ignored because pressure is always high. It's so important to control the blood pressure. We have seen patients dying after coming to our casualty, dying on the way going to the CT scan, dying on the way coming to the theater because of high blood pressure. Most of them will have 150 to 200 blood pressure. So reduce the anxiety of the patient, give enough analgesics, and control blood pressure is the first thing anybody has to do. And decision making depends upon the involvement of the disease, age of the patient, associated comorbidities. Patients can come with malperfusion. Malperfusion, one of the biggest complications of aortic dissection. Patients present with stroke within 6 hours, definitely surgery can be done. If they come later, the mortality is high. Limb malperfusion within 12 hours. Once you correct the dissection, it will improve. Renal malperfusion is much more better. They will survive. And bowel ischemia is a dreaded complication because bowel malperfusion, they will have electrolyte imbalance, lactate high, so much a problem. So we have to treat that first before we do the primary treatment. So the principle of the treatment in type A dissection is to excise the intimal tear, where is the entry point, and obliterate the false lumen, because as we have seen in the first slide, which I showed in the animation, these layers are separated. So you have to stitch all the 3 layers together and put an interposition graft. And if there is aortic regurgitation, we have to correct the aortic regurgitation either by resuspending the valve or replacing the valve. So we can either, if the valve morphology is good, in 50% of the cases, the valve can be spared. Valve repair needs expertise. This is what just replacement of the ascending aorta. Here we replace the aortic valve and ascending aorta called Bentall's procedure. Here we conserve the valve. And depending upon the distal limit, these are all highly complex operations. Just for completion's sake, I am putting. It can be done only in very, very experienced centers. We do all this routinely because total arch replacement, then tackling the descending aorta with a stent grafts called the frozen elephant trunk. All these are available. Earlier on, most of these endografts were not available, but now everything is available here. But only thing is the cost is this particular graft, what you see here, cost about 9 lakhs, this arch graft and this thing. That is the best in a type of dissection if it can be done. Patient is stable. Almost, if you do that operation, the long-term results are much better and good. Distal aorta remains remodeled and patient do well. So, of course, you need a cardiopulmonary bypass with hypothermia. If you have to tackle all the organs has to be preserved. As you can see, you have to preserve the brain, you have to preserve the kidneys, you have to preserve the spinal cord, you have to preserve the coronary arteries. All those things have been done during the operation. And this is just to show how different types of aortic dissection. Patients taken in acute dissection, we have taken short videos to show how they present. And this is a patient actually who was living, I was just telling you how the patients die. Patients ruptured aorta. This patient was living about 5 kilometers away from the city, from our hospital. It was done about 5 years ago. Only reason she survived was she was brought to the casualty immediately. Otherwise, she would have died. When you open the adventitia, you can see there is a hole in the ascending aorta. So through which blood is leaking, and see how thin is. The life is just depends upon the thinness of the adventitia. If the pressure goes up, it ruptures and you'll die. That's why I was just telling you, just to show an example how one can die with hypertension. Just because, so as early as possible, when a patient comes to our casualty with a diagnosis of acute type A dissection, within half an hour I can do an operation because we have our team are ready anytime. Straight patient goes to the CT, from there go to the operation theater, whether it is day or night. And I have trained my colleagues also, even if I am not available on the spot, everything will be done and we can save the life, because no question of waiting. Unless only indication for not doing an emergency is visceral malperfusion. All other malperfusion we usually do. These are technical things, how to go on cardiopulmonary bypass, so many ways of doing it. Easiest is femoral artery, then we do axillary artery, carotid artery cannulation to put the patient on cardiopulmonary bypass. And you see that patient had an acute type A dissection, the blood clotted luckily the blood is clotted in this case, that has protected the patient from rupture. So you can see the amount of blood clots in the ascending aorta, just to show how important it is to tackle these cases as early as possible. And this is now checking the aortic valve. In this patient, the aortic valve is competent. I am putting water in the ascending aorta. You can see transected aorta, which is dissected, and the water is holding. That means the valve is competent. In this case, we can leave the valve alone without replacing. Now, the operation can be done with the hypothermia. So what we do is, olden days used to do total circulatory arrest. That is, you cool the patient to about 15 degrees centigrade, arrest the whole body circulation, but then operation has to be completed within about 50 minutes. Otherwise, patient can have permanent neurological damage. Now what we do is, you perfuse the brain, antegrade through both carotid arteries, and cool the patient only to about 22 degrees. 24 degrees. So hypothermia is avoided. Deep hypothermia is avoided. Moderate hypothermia we do it because brain is always perfused. You can see that through the subclavian artery, the right carotid is perfused. The left carotid, we are placing a cannula and perfusing blood at about 24 degree centigrade so that brain circulation is maintained. So now distal anastomosis is under open clamp. Now what I am stitching is the distal aorta close to the aortic arch vessels. So that is use Teflon pledgets to prepare the aorta because one of the dreaded complications after surgery is bleeding. All these suture lines can bleed and can create lethal problems sometimes. So it has to be properly prepared, and then we suture a graft to the distal aorta. Now to prepare the proximal aorta, that is in the proximal part close to the aortic valve also is dissected. So when we retain the aortic valve, we have to make sure these suture lines also are properly fixed, so that sometimes we use glues so that to reduce the bleeding in the needle holes. This is how it looks after surgery. The clean field. Sometimes it may not be as clean as this. Just to show a few of these operating pictures, pre-op and post-op. Depends upon the tissue. This is a patient who had a type A dissection, a young girl, about 25 years old. She came with aortic dissection. That is the post-operative picture you can see with the graft and aortic valve. These are a few of the cases where type A dissection we have repaired. This is just ascending aortic graft replacement. This is a patient who had a coronary bypass surgery elsewhere. You can see the aorta dissected here because of the side biting clamp. And then this is the post-operative picture after the repair. Ascending aorta replaced. And this is a patient, actually we operated just 2 months ago. In fact, it's the first case done in our country. In the world literature also I have not found out any case. That is a patient we call Cartagena syndrome, bilateral bronchiectasis, dextrocardia with situs inversus, came with a type A dissection. It's a very difficult case to do. And you can see that the heart is on the right side. Aortic arch is on the opposite side. Still he has got a distal aortic dissection. I just want to show that how the aortic dissection extends up to here. So these type of patients we follow up and see what is going to happen later on. So what happens if only the ascending aorta is replaced alone? So what happens to distal aorta? It becomes enlarged depending upon the entry point and the extent of the aortic dissection. You can see all these follow up. You can see distal aorta is still not normal. They may need secondary procedures, so they need a follow-up to do that. This is a case I was telling, the total aortic replacement. In this patient with the type A dissection, we replaced the whole aorta, arch and descending aorta. It's called frozen elephant trunk procedure. This graft is, that graft cost I was telling you about 9 lakhs. This graft will close, this graft. That is, it contains the arch vessels and the descending. This is a stent graft actually. You can see how the graft is being deployed into the aorta. Once the aorta is cross-clamped, we open the aorta, give cardioplegia. That is for myocardial protection. We give cold crystalloid cardioplegia. The different cardioplegic solutions are there. Then the aorta is being prepared to stitch the graft in the proximal part, as I showed you in the previous slide. Now that is the distal aorta. You can see the arch vessels. You can see the subclavian is there. I'm cutting the subclavian artery, and that is the carotid artery. And then we deploy the graft inside. So that is the graft I was telling you. So in the descending aorta, you are putting a stent graft. Stent graft is being introduced there. I'll just fast forward a little bit, otherwise it will take more time. Now you stitch that. That is the distal aorta is being stitched. After that, we start the body perfusion, lower body perfusion. And you can see all the arch vessels being, now the heart is perfused. Once you release the cross clamp, the heart will start beating. Now we step by step, we anastomose the arch vessels and they complete the operation. These are the patients, sometimes they can have bleeding problems post-op. We have to be very careful. Every stitch has to be taken. We all say the 4 P's in aortic surgery is, that is patience, P-A-T-I-E-N-C-E, proline, protamine, and prayers last to have a successful aortic surgery. Because sometimes things may not be in your hands. You may do the best operation and the bleeding will not stop. So we can only pray and stay. This is also another graft which we have used, which we have published actually. First time done in our country in November 2020. Same operation. And frozen elephant trunk alternatives, we do debranching procedures in the aorta. Instead of replacing the ascending aorta. So in a given case, we have to do what is necessary. This is a new complication we see nowadays because, as you know, you would have heard about putting stents in the descending thoracic aorta. So a very dreaded complication is aorta can dissect retrograde into the ascending aorta. So retrograde is a iatrogenic problem. It is an acute retrograde dissection is almost 100% mortality. These are all chronic dissections where we have to treat the ascending aorta. Sometimes we have to replace the arch also. This is one of those cases where we operated retrograde dissection. It's stent grafting done elsewhere. You cannot see any entry point in this aorta. Entry point is distally. This is a retrograde dissection coming from the descending thoracic aorta. So these patients need fixation of the descending thoracic problem later on. So malperfusion, as I mentioned earlier, it can happen in every organ. And the most important complication in aortic dissection is this only, malperfusion. Depending upon, some patients may not have malperfusion and it has to be treated properly. Otherwise, you can have a high mortality. So at the time of cross clamping, or this patient actually, these are the commonest is coronary. Then you can see most common is the renal malperfusion. You can see this is malperfusion of the periphery. This patient comes with a pulseless lower extremities. A couple of cases they have done embolectomy for lower limb. So in the case of aortic dissection, because the primary part was not diagnosed. You can see that afterwards they will all have a good perfusion of the lower limbs. Most of the cases of peripheral malperfusion, we just do the primary correction. Coronary malperfusion, you can see, you can do coronary bypass graft. This also is coronary bypass graft with aortic arch replacement. And cerebral malperfusion, as I said, if they come with a serious patient is, if the GCS score is high, normally we don't operate. And if the patient comes after about 12 hours, because the complication rate is high, but even though medical therapy, 100% mortality, and in serious cerebrovascular accidents, the mortality comes to about 75%. Mesenteric malperfusion is a very highly risky problem. Patient will be very sick. Usually, if we can do some endovascular procedures to or put a stent in the mesenteric vessels, when the patient improve only, we take the patient to the theater. Otherwise, sometimes they will have gangrene of the gut. I've seen cases when you do a laparotomy, the whole gut is gangrene. Those type of cases, nothing can be done. Almost we have to give up. And then we have also published our results with in one of the journals. Limb ischemia, of course, as I showed you, this is how it looks. After surgery, you can see the limb perfusion. Actually, when it comes to the true lumen, lower limb perfusion automatically occurs, almost in 90% of the cases. This is a patient, actually, a young fellow. He was only 35-year-old fellow. On a Sunday, he went to sleep after lunch, and he could not move his lower limb. He was brought with the paraplegia. And you can see the aorta is cut off just above the bifurcation. Then we had to do a emergency surgery on a Sunday afternoon. Immediately I operated, replaced the total arch and did a axillofemoral bypass, you can see. And he walked home on the 15th day. He was about to fly in the night to US. He was a software engineer and he was a paraplegia, he was brought. And luckily we could save him because he was near the hospital. This patient actually operated last week only. Again, same problem. You can see the lower limb perfusion, and he is on dialysis with a creatinine of 16. So renal malperfusion is another dreaded complication, but one of the problems I find that even if patient has got renal failure with high creatinine, if you correct the malperfusion, they are reversible. Our nephrologist, in the first case, I was very scared to do. A patient who was shifted from Hyderabad. With 21 days, they were dialyzing the patient because of acute renal failure. Type A dissection, B dissection was missed. So the moment we put a stent on the table, he started passing urine. With a creatinine of 12, shifted from another hospital, I can show you the post-op picture. So the kidney all perfusion improved and he went home. So now come to type B dissection. It's a huge topic, so I won't take too much time because I thought I will cover all the aspects. So type A dissection, type B, we have finished the management of type A dissection. Now come the type B, where the entry point distal to the subclavian. It can be complicated or uncomplicated. So complicated are then when there is rupture or clinical malperfusion, or patients with recurrent pain after type B dissection, if the patient is having pain more after 12 hours, or hypertension, because uncontrolled hypertension or radiography features of tear, aortic diameter more than 4, or false human is more than 2.2, or bloody pleural effusion or radiographic only malperfusion. If these are the only indications of interference, that is either a stent graft or surgery in complicated type B dissection. Uncomplicated type B dissection, medical treatment is the answer, at least in our country. There are a lot of trials people do with the stent grafts, but I must tell you that, now anybody who has got a hammer, whatever you see is a nail. That is the attitude in most of the centers. If you get a patient with type B dissection, lot of patients, because vascular surgeons do, intervention radiologists do, cardiologists do interventions, and surgeons operate. So certain cases with the stent graft also, some without indication also stents are being put, and then they come with another problem. In aortic surgery, from my experience, I noticed that if you do a wrong procedure at the first time, that is the beginning of a problem. You can get away telling the patient that, that is okay, secondary to that. Then the primary, if you have done something and a wrong treatment, it is just a chain reaction. Because if you put a stent, it can, as I told you, so many complications can occur, retrograde dissection, infection, so many problems. So guidelines of type B dissection, I just want to show you. As I told you before, medical surgery is only when there are complications. Just to see how aorta can dissect. This is actually a 25-year-old boy came with, this is the problem. He has no risk factors, just the whole descending thoracic aorta. This is his sister. 4 years later, I operated this boy, successfully replaced the thoracoabdominal aorta. 4 years later, he brought his sister. They are from Salem. Because his brother did well, they both are Marfans only. And this is the post-operative picture. You can see the whole aorta replaced. This is the sister's CT, and that is the brother's CT. Post of the whole aorta was replaced from the subclavian down up to the bifurcation. And that is the frozen elephant trunk procedure which I showed you, where the stent graft, with that video which I showed, that is for a chronic dissection. This is a patient, very interesting young boy, who presented with the pleural effusion. Somebody tapped his pleura about 5-6 times. This is about almost more than 14 years ago I operated this boy. And when we did a CT, has just come at that time. You see, there is a type B dissection. Fortunately, stent and all was not available. Otherwise, somebody would have put a stent in this patient. For a younger patient, I think direct surgery has got much better results than stenting, because it is a primary correction, and patients may not require any further treatment or further surveillance. One of the problems of stenting, if not done, if it is not necessary, is all these patients need lifelong surveillance. You have to do CT, whereas when you do direct surgery with a graft stitched on that, most of the patients will do well in years. This is another patient also with open surgery for thoracoabdominal. This is how it looks. If you see if the patient see the incision, he will commit suicide if you see this, the incision. We start from the left chest down up to the aortic bifurcation. Exposed picture, if you see, it is horrendous to see this. And that is the scar. That is the boy I was telling, about this starts from here to here. Usually this operation takes about 10 hours. Opening takes about 2 hours, closing takes 2 hours. Another about 5-6 hours to do this correctly. Of course, it is rewarding, especially in younger people. And this is another way of treating them, putting a stent graft and tackle the distal aorta later. This is another patient operated in Mumbai. You can see the graft is kinked. So, and distal aorta is totally dissected. So we have replaced the aortic arch and done up to 2 stents we have put, and now being on follow-up to what is to be done. And that is a very interesting case. That is where the aberrant subclavian artery arising from the descending thoracic aorta, and aneurysm is very rare. This is first time in Asia and second globally. We have done this, we did a frozen elephant trunk. So problem with medical management, currently it is considered as the best option, as I said, in uncomplicated dissections. Subsequent interventions are required only if the aneurysm expands, or progressive dissection, related adverse events from unresolved dissection. Aneurysm formation, false lumen increases more than 25 to 30%. So role of TEVAR, that is the endovascular procedure, just to show an animation how it is being done in type B dissection. The patient has got a dissection. We pass that is the endovascular stent being passed to the femoral artery. It can be done nowadays with the perclose, even without making an incision in the femoral artery you can do. It's totally just a puncture only will be there. This is the delivery of the stent. This stent is nicely sitting in the descending aorta. Distal part is an uncovered stent, so that will approximate the true lumen and the false lumen. So this is technical things for doing the primary tear and secondary tear. We do, these operations can be done without cardiopulmonary bypass. That is a patient, old patient, come with a type B dissection. One of the problems what we face is, as you can see, in this, see, if you put a stent, you have to have at least 2 centimeters for the stent to stay there. You call the landing zone. The landing zone of the stent has to be about 2 centimeters, otherwise stent will slip into the aneurysm. So if there is no enough landing zone in the aortic arch, see what you have to cover the carotid artery here. To cover the carotid artery, subclavian artery, sorry. So to cover, then no perfusion in the lower limb. So we do first a carotid subclavian bypass in the neck, and then you can do a stent graft. So no open surgery is necessary. Then if it is, this is a patient, you can see an aneurysm here, distal aorta, just not enough landing zone here. So we covered the subclavian artery. I did a carotid bypass and a carotid subclavian bypass. So the stent is here. It's almost 8 years after surgery. We took a CT. You can see nicely working. That is, you connect the carotid to carotid to subclavian. So the whole circulation is through the innominate artery. But everything can be done as a closed procedure. No need for cardiopulmonary bypass. Less morbidity to the patient. So this is also another case where you have done. This patient had undergone a coronary bypass surgery. He's a doctor actually. Came with a dissection here. So again, going through the sternum, it's a very highly risky procedure. So we did the same thing, carotid subclavian, and an endovascular stent. Now hybrid means this is actually where we, as I mentioned, there is no need for heart-lung machine. We can use on a beating heart, put a side-biting clamp on the aorta and connect this one graft to the right carotid, another to the left carotid, and put a stent. Same operation. That is ascending aorta we have replaced, and that is the post-operative. Just to show a few pictures of post-op pictures of arch debranching with endovascular stenting. Same with this patient had a aortic root replacement. He had a ruptured sinus of Valsalva and type B dissection. So we did the whole thing together. Now what happens in Marfan syndrome? That is what we see. These are all straightforward Marfan syndrome patients who had aortic root replacement. You can see they develop sometimes distal dissection. Distal thoracic aorta get dissected for no reason because their aortas are basically fragile, connective tissue disorders. So Marfan's patient usually need lifelong surveillance. Just to show an example, In November 7, actually she was taken to CMC hospital from Singapore. From CMC they referred to me. I did a December, 1 month is a chronic stable dissection. I did a root replacement. February 11, this is the situation. You can see that aorta is dissected, enlarged. I did a total arch replacement and put a stent graft. Now she is still on follow-up, doing well. Same, another patient in 2005, aortic root replacement, distal aorta enlarges, put a stent graft, and this we have to replace the whole with an endovascular stent. This is also another possible thing, that is total abdominal stenting with the stenting of the visceral vessels. This can be, because I showed you an open surgery. This is a technique where we do without operation. But this is not applicable in a very young patient. This patient did not want open surgery. Otherwise, I would have operated this patient. But he is doing well. Marfan syndrome is normally a contraindication. Now, coming to the challenges in India, as I was mentioning, we have problems. For example, I have patients coming from neighboring states being transported by ambulance. Sometimes patient will die on the way, develop ventricular fibrillation, admitted in another. So transportation is a big problem. Unless in most of the centers in the Western countries, they have helicopter air ambulance to bring patients directly, because while attending some American meetings, they were showing in Pennsylvania and all, patient landing on the operation on the hospital roof, coming straight and I don't think we can expect all those things in the near future, but at least we can treat patients who come to our hospital, because they have aortic super centers where everything is available. Air ambulance not fast enough because of, as we all know, about the problems which we face. And the statistics we don't have any reported statistics from India, but extrapolated shows we have about nearly 7 lakhs patients need aortic surgery in India per year. And in reality, you can see how many we are doing. Approximately 400 to 500 cases of type A dissection we are doing per year. Most in winter, October to January, majority of the patient between 40 to 50 years. And so, is the incidence low? We don't know, because patient does not, sudden death we attribute to some other reasons other than aortic dissection. So another thing, we did a study recently, we also published that paper. Diabetes has got a positive role in protecting aortic aneurysm. This is coming to aneurysm, not dissections. People who are diabetic, we did an analysis and found they are less prone for aneurysmal disease. Another thing is availability of grafts in India, because we don't have ready-made grafts, especially when you need arch reconstruction. Now only we are getting it, or we can make our own grafts. This is what I used to do about 10 years ago. This graft is ready-made available. It is still not available, so we have to use our expertise to stitch all these things. But the problem with stitching here is sometimes all this can leak and have additional problems, but still we can do it. Necessity is the mother of invention. So this is a ordinary theater in abroad. What you can see is they all have hybrid theaters, which cost about nearly $4 million. So I don't have a hybrid theater. Hybrid is of $4 million, and this is what we have made in our hospital. We have got a screening machine from the orthopedics department, and then we use it along with the transvasagial echo. So if I wait for a 4 million hybrid suit, I will never do an aortic dissection. But we are proud to say that we are doing all these things with available facilities. We cannot say that, I always tell my assistants, you don't wait for a perfect place to work. If you take the scale of 10, if 5 is in your favor, for me it is the best. 6 is excellent. Don't expect more than 5. Any place you were there, because every time they go somewhere and say, sir, I don't have it, we don't have it. I said, if it is like that, I would never have done aortic surgery. Earlier on, I never seen a video, never seen somebody operating, getting journals. First aortic arch aneurysm I did in 1990. Patient is still alive. She's a nun sister. She comes and lights lamp for our aortic meeting. I conduct aortic workshops every 2 years. So she is still alive. So, but that I read the journal, the aortic for elephant trunk, how it is being done. Previous day we rehearse. They always tell operation does not start at 8 a.m. in the morning. It starts 8 a.m. the previous day. Don't come to the theater just like that. Prepare. Preparation is very important. That is Abraham Lincoln's famous word is there. If I am given 8 hours to cut a tree, I spend 6 hours sharpening my axe. and I use only 2 hours to cut the tree. So sharpening the axe is very important, which many not people, even one of the famous cardiac surgeons, John Kirklin, very famous. So he has, in his book he has written, when he is doing a very complicated case, previous day he makes notes in a paper. Morning he come and give it to the anesthetist, the steps of the operation, so that you don't make any mistake. So it is just for the junior surgeons to, to learn all this. So financial burden, as I told you, it's expensive. This is just an experience of what I have been doing. We have done about close to, this up to 2019 only. Now we do more aortic cases, almost about 70 to 80 cases a year we do. And aortic dissection, we have a mortality of about 5.6% aortic dissection. Normally the mortality varies from 5 to 15%. A study was done in the US to find out the incidence of mortality related to the volume of work. And they found that centers doing about 3 to 4 cases a year have got a 25% mortality for aortic dissection. Centers who do more than 10 or 15 cases, the mortality comes to 10. Those who do more than 50 cases, the mortality is around 5 to 7 still. So with all these limitations, we were able to produce reasonably good results. I am happy to say that. To conclude, acute type A is an emergency and surgery is the treatment. When the aortic root is involved, aortic valve repair or replacement, and never regret for replacing the aortic root. If you are not experienced in doing aortic valve repair, do not try to repair, because root replacement has got very good results. Malperfusion is a serious complication needing individualized specific approach, and it has to be tackled according to the site of malperfusion and the importance of a good diagnostic radiologist. Distal aorta, as I showed you in Marfan syndrome, it can increase in size and may need secondary interventions and multiple challenges to overcome our Indian settings, and should not be a criteria not to do this. Frozen elephant trunk, as I showed, good long-term results. In type B dissection, hybrid and TVAR is the preferred management. In complicated acute, treatment of choice is surgery or TVAR. Surgery in complicated type B carries higher risk. So nowadays people defer surgery in type B whenever possible. Early, thank you for giving me this wonderful job opportunity to address all of you. Thank you.
Thank you, sir. Thank you, sir, for that wonderful talk. Now we will break for tea, which has been arranged in the MS office lawns. So I humbly request everybody to please be back in 15 minutes. Ground floor, yeah.
check. Hello. Hello. Hello.
Sheikh, hello, hello. Sheikh, hello, hello, hello.
सामने चल जाना है। चलो ठीक है, कोई बात नहीं। Welcome back to the event. Now we will begin with the presentations by the guest speakers. I request the chairpersons, Dr. Vijay Kumar Sharma, Director CTVS Department, Ludhiana Mediways. A round of applause, please. Dr. Vikram Pal Singh, Associate Professor, Hero DMC, Ludhiana. Dr. Harshbir Singh Pannu, Senior Cardiac Surgeon, Holy Heart Hospital, Amritsar. To please chair the next session, which will be Leaps and Bounds in Aortic Surgery by Dr. Santosh Mathew. A few words about Dr. Santosh Mathew. He is the head of Department of Cardiothoracic and Vascular Surgery at Ahalia Hospital, Abu Dhabi. He is an alumnus of Christian Medical College, Ludhiana. He did his MBBS and MS from CMC, Ludhiana, and MCH in Cardiothoracic Surgery from GB Pant Hospital, New Delhi. Thereafter, he worked as a lecturer and reader in CMC Ludhiana from 1989 to 1995. And during these 7 years, he performed over 5,000 cardiothoracic surgeries. He then moved to Thrissur Hospital, Kerala, and performed over 3,000 surgeries there, which includes the first successful aortic root replacement in Kerala. Thereafter, he joined Al Qasimi Hospital, which is the largest referral hospital under Ministry of Health UAE, and there he established the Department of Cardiothoracic and Vascular Surgery in 2003. Then in 2016, he joined Ahalia Hospital UAE and established the Department of CTVS there as well. He has over 30 years of experience in the field and is a pioneer in the field of minimally invasive cardiac surgery, off-pump beating heart surgeries, complete arterial revascularizations, and video-assisted thoracic surgeries. He is also a member of the European Association of Cardiothoracic Surgeons. I hereby invite him for a presentation on leaps and bounds in aortic surgery. Dr. Santosh Mathew, sir, please. A round of applause.
Thank you for the very kind introduction. Respected chairperson and ladies and gentlemen. I would like to thank the organizers, especially my colleague, junior colleagues, Alan Joseph, Medical Superintendent, Dr. Navneet Chowdhury, and my friend, perfusionist, Mr. Jairus, for inviting me for this function. I am extremely privileged to be here in this function because I owe everything to this place in my profession. I have acquired all my surgical skills in the operating theaters here. And I was able to perform in all the places where I went because of the training from this place. And about Dr. Eggleston, what I remember is that when I first joined the Department of Surgery, what boss said is that he asked me that, do you know where the toilet is? And the second thing was, you know, where you have to eat and where you have to sleep. So he said that is enough for you, and you just keep working, provided you do your work well and don't quarrel with the nurses, everything will be fine. So, and Dr. Eggleston, as Dr. Navneet has mentioned, he has made that American residency system here, pyramidal system, that is the most effective surgical training. And when I joined this department, this was the most glamorous department in this hospital. And we were actually doing everything, starting from carotid angiograms to, you know, pacemakers, everything that was, you know, a little bit invasive, everything they used to call the Department of Surgery. And so I will start with, I'll come to the topic. the leaps and bounds in aortic surgery. Most of the advancement in aortic surgery is the contribution, as Dr. Bashi mentioned. It's about from Dr. DeBakey. DeBakey clamps, DeBakey forceps, things that we use in our daily practice. And even a total artificial heart, first that was the contribution of DeBakey. And he established a very good surgical team in Baylor College with Denton Cooley and Stanley Crawford. And I had an opportunity to visit this place with the help of Dr. Gill, Dr. Sarjit Gill, who gave me a letter to go to Houston. And then I went there, then I went to Cooley's theater. I was actually that time expecting that there is some magic from his hand because he is so well known. And I saw Cooley just, I didn't know that it is Cooley who is operating. He just lifted up his head to see that who is the visitor. And it was written on the side of his loop, Denton Cooley. And he was suturing with not with the Castravijo needle holder, with the ordinary needle holder, just like anybody else. Didn't see any magic, but Cooley's there was in history of cardiac surgery, there is the big feud between Cooley and DeBakey, and we used to enjoy that. There was a book, The Hearts, that used to be read during our residency. The fight between Cooley and DeBakey. It all started with Cooley took the technology from the Baylor College lab and did the first total artificial heart transplantation, artificial heart. The patient lived for 3 days, but Cooley got the name, and from that time they were not on talking terms for 40 years. And the feud continued, and this is the great handshake after 40 years, and ultimately it got patched up before their deaths. And sometimes a disease gets universal appraisal when celebrities get disease. John Ritter was a very well-known and well-liked American actor. At the age of 53, Ritter was rehearsing for some show, and suddenly he had severe chest pain and sweating, and he was immediately taken to the nearby hospital, where he was diagnosed as acute myocardial infarction, and he was treated as such. But later on found to have acute aortic dissection. But then he could not be saved. And then, because he was a celebrity, his wife sued the hospital and the doctors for negligence. About $67 million suit was filed. And the hospital suit was settled with out-of-court settlement of about $6 million US. And the case against the doctors was that against the radiologist and the cardiologist. Radiologist for not picking up an aortic aneurysm in a scan done 2 years earlier. And for the cardiologist for misdiagnosing the condition as myocardial infarction and for the wrong treatment. But then his widow started this foundation, Ritter Foundation, and made, for the public to know the how to diagnose aortic dissection, how to the precautions that you have to be taken. And so that is why the research work on aortic diseases is by this Ritter Foundation. Aortic aneurysm is a general term for enlargement of the aorta greater than more than 1.5 times the normal size, and the causes are multifactorial. The end result is an underlying weakness in the wall of the aorta at a location, and all aneurysms keep on increasing in size until they rupture according to the Laplace's law. And the causes of there are genetic conditions that cause aortic aneurysm like Marfan syndrome. All of us know about Marfan syndrome. It is because of a mutation of this gene, particular gene, and that causes there is transforming growth factor 1 that increases in Marfan syndrome. So in families where there is Marfan syndrome, for their children, they may be benefited if they are started on losartan, because losartan will decrease the level of this transforming growth factor. So that may reduce the chances of aortic rupture. And then this Ehlers-Danlos syndrome and Lloyds-Dietz syndrome, and then familial thoracic aortic aneurysms with the dissection bicuspid aortic valve, then Turner and Noonan syndrome. Then the other causes, idiopathic medial degeneration, dyslipidemia, vasculitis, and microbial infections like syphilis, mycotic aneurysms, autoimmune disease, cocaine, amphetamine, and post-stenotic aneurysm, and aortic trauma. And you know the features of Marfan syndrome, how there is unusual length, and the arm span is more than the height, and hyperflexibility of the joints. And along with that, there is aortic annular ectasia. And in Ehlers-Danlos syndrome, it is the problem with the collagen. So the collagen forms the reformation if you are pulling the ear, and it is going back because of the collagen. So in this syndrome, it may stay like that, same thing with the skin. And Lloyds-Dietz syndrome mainly affects the ascending aorta along with the other major congenital anomalies like hypertelorism and split uvula, and then abnormal twisting of the arteries. Syphilitic aneurysm affects, it is quite rare now, it affects basically the ascending aorta. That is because of the increased vasa vasorum of the ascending aorta. The syphilitic treponema that lands in the vasa vasorum and causes an obliterative arteritis. And that is how, and dissection never occurs in syphilis because of the scarring. And pathology includes atherosclerosis, decrease in the number of smooth muscles in the aortic media, fragmentation of the elastic lamina, signs of local chronic inflammation of the aortic wall, and neovascularization. And this slide, I think Dr. Bashi has shown, these are the layers of the aorta. And the aneurysm affects ascending aorta, thoracic, and any part of the aorta can be affected. And the most important symptoms, it may not produce any symptoms at all. And it is described as a silent killer. You can have a abdominal aortic aneurysm and then suddenly collapse and die with rupture. And till it ruptures, it may not be diagnosed. And as the enlarged symptoms appear, and pain in the aneurysm is a sign of impending rupture. When it rupture occurs, massive internal hemorrhage results, and unless treated immediately, shock and death can occur within minutes. And this graph, the first graph is of the ascending aorta, and the second one is of the descending aorta. You can see that more than 6 centimeter, the rupture rate is steeply goes up in the ascending aorta, whereas in the descending thoracic aorta, that it happens after 7 centimeters in size. Although the recommendation is more than 5 centimeters in size, you have to you do an intervention. But many times we find that sometimes we tell somebody who is known to you that you need surgery and they refuse, and you may find them still okay after 10 years. And so we cannot predict that it will rupture in a particular period. And now This ELISA linked kits are available for desmosin. Desmosin is a amino acid that links the elastin tissue together. And when this, before rupture, this desmosin gets discharged into the blood and the urine. And you can pick it up in the blood test and urine test using a kit. And it is not freely available. It is still under investigation. So this may tell you that aneurysm, the chances of rupture of an aneurysm. But in general, it is taken that more than 5 centimeters should go for surgery, especially for the ascending aorta. And the diagnosis on physical examination, you can pick up aortic aneurysm. Like infrarenal aneurysms, we can put the finger below the costal margin and get above that aneurysm. But because of the wonderful medical imaging technology, now precise diagnosis has become very easy. And with the CT scan is the gold standard investigation. And then the pain of aortic dissection, especially when dissection occurs, the pain is the worst pain that can happen, supposed to be. And the patient has severe pain, and it is unmistakable. It is supposed to be worse than the myocardial infarction. Treatment options, surgery or endovascular stenting. It is a definitive treatment of aortic aneurysm. And medical therapy is reserved for smaller aneurysms for elderly frail patients, where operative treatment is more riskier than the observation alone. And the gold standard of treatment is endoaneurysmography. And it is long-term results are good if it is done properly without recurrence. And this is what is done. The graft is, the aneurysm part is replaced, and usually it is wrapped with that diseased aneurysmal wall after cleaning it up and making multiple holes so that nothing collects between the graft and the aortic wall. Endovascular repair has now attained popularity. It is in uncomplicated cases, elective cases, in selective cases, as Dr. Bashi was mentioning, and it is very effective and to avoid extensive surgery. And this I am skipping because this is already shown. The balance between the risk of aneurysm rupture without treatment versus the risk of surgery, and the decisions are made according to that. Elective surgical repair when as I said before, when the diameter is more than 5 centimeter, and open endovascular graft insertion is the treatment of choice. This is the slide showing the classification which already Dr. Bashi has shown. Now I will show a few cases which I have done. And this is a patient, young lady with the Marfan syndrome, Emirati lady who came with the huge ascending aortic aneurysm. You can see that the aneurysm is extending from the vertebra till the sternum. And we did this is the surgical procedure that is done. That is the classical Bentall operation, where the aortic root is replaced along with it is done with a valved conduit, and the coronary arteries are reimplanted onto the graft. And here, this on the right side, you can see the aneurysm, and that is a post-operative picture. You can see the ascending the graft in the ascending aorta. I will just show a video of the short video of this procedure. That is the aneurysm. You can see the paper thin aneurysm. Dr. Bashi has shown some video before. This is the thin aortic wall, which is with impending rupture. And this is one of my earlier cases where soon after going from here, I have done it in Trichur. And that was a time when valved conduits were not available, and so we have to make a conduit suturing a valve into the thing. You can see the inside how thin that aortic wall is, and inside that you can see circumferentially transected aortic media. That is the transected aortic media. And the aortic annulus is ectatic and severely ectatic with a severe aortic incompetence. This patient also had been initially treated in a hospital for myocardial infarction. He has got thrombolytic therapy. So that is the cardioplegia is being given, and then that is the aortic cusp. Cardioplegia to the both coronaries. We used to do at that time one after the other cardioplegia, and that is the frail aorta being trimmed. And this is being replaced with a graft. The distal end is reinforced with a Teflon felt outside and inside. You can see this is the aortic, the sutures are taken in the aortic root. Now that is the valved conduit is placed. And holes are made where exactly at the points where the coronaries orient. So that is the sutures are being tied, and the holes are cut out for reimplanting the coronary arteries. And that is the coronary reimplantation. You can notice that the dissection is extending on to the coronaries, and this is the after releasing the cross clamp, and this patient did very well. This is one case where this is done in Abu Dhabi. This is a Pakistani male patient. It's a large aneurysm of the aortic root, that is to one side, and you can see that there is calcification of the coronary ostia. So first we have to do a coronary bypass, and after doing the distal anastomosis, then we replace the aortic root, and then did the proximals onto the aortic root. So that is the another picture of the thing. And incidentally, this patient had a severe aortic coarctation, actually aortic atresia actually. There was no lumen between the upper and lower part. So initially we were debating on whether to do that surgery also along with that, but since this patient was older, he was around 55 years old, and he was not having any problem in the lower limb, and the collaterals were very good to the lower limb. So we didn't do that. So you can see the size of the mammary arteries so big. And there is another case is a 48-year-old Syrian gentleman. He was working as a nightclub singer in New York, and with the recession he lost his job and he came to UAE, and he was a hypertensive. He skipped his medicines, and his wife was an air hostess, and when he was talking to his wife over the phone, suddenly his speech became slurred, and the phone dropped, and he just fell unconscious. And the wife from another country rang up the Sharjah police, and Sharjah police broke open his house, and then he was found unconscious totally unconscious, and he was brought to the hospital, and he was initially treated as a case of stroke with first went to CT scan, and then in a NICO it was picked up that he had a extensive dissection of the ascending aorta and going to the aortic arch. And So echocardiogram showed pericardial effusion, concentric LVH with good LV function, dilated ascending aorta and thrombus. We can see in the CT that ascending aorta, the dissection, and that is the true lumen that is seen with the dye. That is the another CT picture. This is the surgery that is being done. His ascending aorta and hemi-arch is replaced. It's a short video of this procedure. He had a significant hemopericardium. This case was done under, because it was involving the arch, it was done under profound hypothermia and total circulatory arrest in an adult. That was the first case done in UAE with that technique. The cerebral vessels were perfused by a side limb from the main cardiopulmonary bypass. He was in tamponade. As soon as the tamponade is released, his urine output, everything picked up. That is opening the pericardium, and you can see the clots in addition to the free blood. That is cross-clamping the aorta. You can see the dilated, and clots have formed in the false lumen. False lumen thrombosis was there. You can see the thrombus inside the false lumen. Yeah, that is the end result. That is the patient and his wife. They are doing very well. He got back a job. He got a job in Sharjah University as a music teacher, and still working there. And this is a post-operative CT. This is another. This is a Filipino patient, Catherine. She came with the chronic aortic dissection that is involving ascending aorta. It was not involving the valve, ascending aorta and the aortic arch. And descending thoracic aorta is normal. And this patient, you can see the CT. That central small slit is the true lumen, and the side is the just filling from the sides. These are the different slides. And this is the graft that was used for this patient. We have these grafts available. This is expensive, but most of the things are covered by insurance there. So that is not an issue. And so I don't have the surgical video of that case. This is another case, earlier case. That time we used to do the angiograms also. This is a case that was done in Trichur, thoracoabdominal aneurysm. And the classical approach used to be the thoracoabdominal incision. And here, that is the thoracic part, that is the normal aorta, the aneurysm starting from here till here. And this is the diaphragm. This is the diaphragm. It is involving almost to the superior, to the celiac artery. Celiac artery was reimplanted on this case and till the superior mesenteric artery. This is because the open technique is still the gold standard for this repair, but soon maybe this technique may die down, because now everybody will go for stent repair. Although the long-term results of stent repair, is still not known. And one thing I can say is that this open repair is, if it is done properly, it is safe and it is long lasting. This is a case with came with the severe pain. This is a case of ruptured thoracoabdominal aneurysm. This was done in Trichur. Came with the bilateral hemothorax. And you can see this. This is the ruptured part of it. Rupture doesn't mean that rupturing into the lumen. Most of the time, rupture is, it is well held for considerable time by the surrounding tissues, and you have enough time to plan and do a proper surgery. And this is the diaphragm, this is the chest side, and that is the abdominal side. Here, after the graft replacement, you can see the clots there. After rupture, this is the clots in the false lumen. It's another case of infrarenal abdominal aortic aneurysm. That is being replaced with the graft. And whenever these kind of shapes, these are older slides, now everything is a CT scan, hardly these kind of angiograms are done. In the previous time, these angiograms, we used to do these angiograms ourselves. And see, whenever there is a geometric shape like this, these are all dangerous signs that, it is either ruptured or it is impending for rupture. This is a thoracoabdominal aneurysm presented with dissection and paraplegia. Now, one more case I will present. That is a 29-year-old male staff nurse from Philippines. He was referred with a huge suprarenal abdominal aortic aneurysm, 10.8 centimeters in size, and in diameter, and 21.3 in length, extending from below the level of celiac artery with involvement of the superior mesenteric artery origin, renal arteries and inferior mesenteric artery. And this patient went to many hospitals and nobody was willing to do his surgery because he is a young fellow, and mortality in young people will invite investigations, and so nobody wants to take a chance there. And so this patient was taken. You can see that this is already, it has ruptured and formed a sac like that, and the aneurysm is extending. This is the incision. This is the thoracoabdominal incision. That is the surgical procedure. That is opening the aneurysm. Thrombus, organized thrombus has formed all inside the aneurysm. Like a football, it just comes out. That is one part of it. And the ruptured part, I was wondering whether I was removing part of the liver because it had the same consistency. Because this patient had a renal artery involvement and there was hypoplastic kidney on one side, and hence we decided to do it under hypothermia. So we did it on cardiopulmonary bypass, cooling the patient to preserve the kidney, and from one limb of the bypass circuit we have individually perfused the renal arteries, and that is the grafting that is being done, perfusing the renal artery with a catheter. That is reimplanting the renal artery onto the graft. So that is just, this is the surgery that is being done. That is the normal kidney, and that is the hypoplastic kidney. And here an interposition of a 8 millimeter graft was required because of the length was short. This post-operative course was a little bit stormy. He had a renal failure, he had a transient hepatic failure, transient pancreatic dysfunction, bowel motility problems. He required hemodialysis, and he completely recovered. His kidney function completely recovered almost after 3 months. His creatinine became around 2, and he was making good amount of urine, and he is doing very well in Dubai. So that is all the things which I have to, now regarding the new things in for this kind of surgery. Lot of improvement has come in the monitoring, like use of artificial intelligence for monitoring. That is a new innovation that has come. So Edwards company has made a device whereby just from an arterial pulse they will be able to analyze and give you the cardiac output, systemic vascular resistance, and so you can make your drug interventions accordingly. And there is the hypotensive event can be predicted much before it is happening. So that is called the hypotensive prediction index. If that value goes less than, if it goes more than 80, you have to be very alert, and it will give the warning. This kind of monitoring devices help for the nurses, to pick up problems that is happening in the post-operative period. And intraoperatively, these cerebral functions are monitored by cerebral oximetry. So that is an added advantage which was not there before. And then with the new technology of the grafts and then endovascular technology, whole lot of improvement has been come in the aortic surgery. Early detection of abdominal aortic aneurysm is life-saving, as it may be asymptomatic till it ruptures. For all patients more than 65 years should have an ultrasound abdomen as a routine investigation. And if there is a family history of aortic aneurysm, there is 10 times more chance of developing it. So those with the family history of aortic aneurysm should undergo ultrasound. Then hypertension should be controlled with appropriate medication, and pain in presence of aneurysm, you have to take it for granted that it is rupture, it indicates rupture, and definitely should go for further investigations and surgical intervention if indicated. And ascending aorta more than 6 centimeters and abdominal aorta more than 7 centimeters warrants urgent surgical repair. And endovascular stents are appropriate in selective cases, and long-term results are still uncertain. And with improvement in technology, now previously it was thought that surgical dexterity is the main thing, and very skilled surgeons. Now slowly that will be, technical dexterity will replace surgical dexterity, because of the imaging, the improvement in the imaging techniques, and you can operate with sitting in a console and controlling with the just like playing a video game. That kind of technology is definitely going to be the future. If you are offered one of the following tests free, which one will you select? MRI of the brain, coronary angiogram, ultrasound abdomen, echocardiogram, and PET scan. So which one will you take? Ultrasound abdomen. Yeah, correct. That is the thing. So thank you very much for this.
Thank you, Dr. Santosh Matthew, for the excellent presentation. It was really a academic feast for everybody. cardiac surgeons and the other staff here, and you covered the entire topic very, you summarized it very well. And as you said, that technical dexterity has replaced surgical dexterity. That's true, but still there is a lot of role for the routine aneurysmography and conduit replacements that you have shown. No wonder the chimneys and all these things are promoting endovascular aortic repair. And still, these kind of surgeries are often necessarily done with a little bit of modification here and there. I would like to keep the session open for anybody who wants to ask any question to Dr. Matthews. Dr. Kohli from Jammu.
Thank you, sir. It was an excellent presentation. Just one point about the size for intervention. In our situation, 7 centimeters for abdominal aorta, we think that it is too far because the type of surveillance which we are having in this part. So above 5.5, we think we are alarmed and we think of entering the patient.
Yeah, more than 5 centimeters, definitely we should advise, but many patients may not be willing. You may come across your own relative sometimes, because I have a personal experience. I told him that this will rupture, but after 10 years he is alive.
Yeah, it's there is a steep rise after 6 and 7 centimeters.
Yeah.
That's what he showed in the slide. One question that I want to ask you in that Philippine nurse that you did it under profound hypothermia.
Yeah. No. That was the first one, that Syrian patient, profound hypothermia, circulatory arrest. Okay. This one, it was done under cardiopulmonary bypass support with hypothermia.
For perfusion of the renals.
Perfusion of the renals.
Did you perfuse the lower body also?
Yes, both. We made a
axillary and femoral.
Axillary as well as through femoral, both sides.
Right.
So the entire organ is perfused. One thing I used to find here is that I remember that one case that was done here. We did the abdominal aortic aneurysm, and then the aortic cross clamp was just released. Suddenly the patient collapsed and fibrillated, and then we could not resuscitate. That was a time when didn't know much about this declamping syndrome. Declamping syndrome, then went and extensively read about declamping syndrome, and then found that you have to release the aortic cross clamp ratchet by ratchet, and that is a time when noradrenaline was not much used. And now things have so much, we are so confident about, later on became confident about declamping. There was no issue after that.
Right.
But no, can I make a comment on the size of
Dr. Bashi?
Yeah. Now, Santosh, excellent presentation, and you have done a wonderful job in Trichur with all the limited facilities with very, very, very big cases.
Thank you.
Regarding the size of the aortic aneurysm, it's very difficult in the sense, it's like now comparing apple and oranges. All the size is coming from the Western literature. From our country till so far, we have not done any study of the aorta, normal aorta. What is the standard size of the normal aorta in our general population? If you look at most of the Western population, they are all much bigger, body surface area is big, diameter of aorta of a normal person is much higher. So in our setup, probably we may have to reduce the size from 7 to 6, like what is mentioning. And we are just, I'm just doing a study because nobody has done a study from India regarding the size of a normal aorta, and so that we can compare it with the Western size for the indications for intervention in aortic aneurysm. So we are planning to study about 2,500 cases, because during the COVID, it was easy for us to get so many CT scans.
Yeah.
So very soon we will be coming out with some data regarding the average size of Indian aorta diameter in Indian population.
Normal diameter.
Normal diameter. Yeah. Obviously it is definitely less. If you look at anything, because I have worked, you also worked abroad. I mean, I worked in Australia for 3 years. The average size of an aortic valve I used to put was about 27 valve. Till today, I have not put a 27 valve in aortic valve replacement other than in a Marfan's patient. Yeah. The size of the aortic annulus is 21, 23 maximum, rarely 25. I'm sure all of you agree who was doing this, even mitral also. Yeah. So definitely their sizes are very big. So we have to do a study to find out how to come out with some sort of classification and indication regarding the size of the aorta.
Yeah, that will be great.
Thank you.
Sir, one question. Sir, congratulations for this phenomenal talk, sir. Sir, in first few slides you mentioned genetics. Do you do any genetic screening abroad?
We, for the local patients, see the local patients will advise for them the genetic screening is done. And for expatriates, it is not covered by insurance. Okay. Because genetic disease is something that is congenital. Insurance doesn't cover that. Okay. So no screening test is covered by insurance.
Thank you.
Hi, Santosh. Congratulations on the very excellent paper you presented. In fact, I remember in early 90s when you were here, we had done a number of dissection of aorta cases, and remembering a publication actually we did in 1993 in Indian Heart Journal, where we had presented 7 cases, and in 5 of the cases you had done a surgery, and we had almost 60% success there. So it's very nice to see that you have come a long way and done such an excellent work.
Thank you, Dr. Carlton. Thank you. One more thing I would like to share. The first aortic dissection that was done here, we have done a Bendal operation. My boss, Dr. Mohan Varghese, was the surgeon, and we replaced the aorta. That time there was no valved conduits were not there. We switched a Star Edward valve onto the graft, and then what he did was that he closed that outside the aneurysm over the graft, like an endoaneurysmography, and closed it so that there is no bleeding issues. And then after about 6 months, this patient ended up with us with endocard, and then he told me that you make an anastomosis between the left atrial appendage and onto that sac, so that if there is any drainage, it will go into the left atrium, so that nothing collects there. And this patient landed up after 6 months with endocarditis, and he had vegetations, he died. And that time, with my enthusiasm, I took him to the downstairs, the pathology, I called the pathologist, and we did an autopsy, and found that that space between the graft and the aortic wall, that was full of pus. And because that communication that we have made from the, for the drainage, that all got closed off. So that was a big learning thing for me, that even if you leave that graft open, it is better not to, even if you wrap around, we have to make multiple holes so that, there is enough provision for drainage. If any space is there, something collects there, and potential for infection.
Right. My question is for Dr. Bashi. Are you doing Cabral also sometime?
No, I have to see the technique what he described is olden days where we used to do the inclusion technique for coronary anastomosis. For the last 20 years I have stopped because there is a lot of, there's an article came from Mayo Clinic, the incidence of pseudoaneurysm in the aortic root when you do inclusion technique is almost 40%. So everybody uses the button technique, dissect out the coronaries separately and put. So the bleeding, whatever is there, you can see and stop at that time itself. Original Cabral technique was used about 30, 40 years ago, where this was not there. So people use excess bleeding will be controlled, cover the aorta with the whatever aorta available, or sometimes people use pericardium and connect into the right atrium. Plenty of every other case in CMC, of course, we used to do maybe one case in 2 months or something. I seen Dr. Jairaj doing all cab rolls only. But none of them had an infection, as you said. No problem at all. It was draining nicely. In fact, one patient came with I could listen like a diastolic murmur, like a RSOV. But patient was all right because the leak is, from the aorta into the right atrium was not enough to produce heart failure. The other cab roll technique which I do is for nowadays is reoperations where the coronary is not very easy to mobilize. So you anastomose a 10 or 8 millimeter graft to the left coronary and bring it onto the graft, main graft, and anastomose on the right side, and right coronary same thing. I have at least nearly about 22 cases I have done Cabral technique for coronary anastomosis. That is using a separate graft for coronary anastomosis to prevent tension and bleeding. Still another way of doing Cabral also is, I do some redos. When people have last week I had one case, one lady who had a 19 tissue valve inserted in another hospital, came for aortic root aneurysm with a calcified aortic valve. So the problem was he has stitched a 19 valve so close to the aorta. When I removed the valve, I'm not able to seat a 19 valve. Even conduit I cannot put a 19. So what I do was first take a graft, 19 valve will go into a 22 graft. So you suture the graft all around in the aortic annulus, okay? And implant the aortic valve about 4 or 5 millimeters above the real annulus of the aorta and do a Cabral technique. So you can do a bigger size valve above. So the hemodynamics will be better. This I had to do. First case I did about 5-6 years ago out of necessity. A patient who had done an aortic valve replacement elsewhere came with endocarditis. Tissues are all friable. I just could not take a stitch because in those situations in a small aortic root, if you make a conduit and stitch there, then in the end, if it bleeds, you have to look up. You cannot do anything. Here, first just the graft alone, you stitch with interrupted sutures, and I take an additional layer with the 4-0-proline. And nicely, sometimes I put a glue in that area, so that area is free. And since you don't do the coronary anastomosis, then you push a graft through the graft, through a valve through the graft, and continuous with suture with 4-0-proline. Then above that, you make the coronary anastomosis. So in this situation, the patient, of course, in redos only I do this. If it bleeds, you can see everything. Annulus you can see, coronary anastomosis you can see. Even if it bleeds, nothing to worry. You are under direct control.
I hear you are putting the valve after the graft.
After the graft. Stitch the graft first.
Graft first, and then
and implant the valve. You have to see through that graft. The valve goes inside about 5 millimeter above the annulus. You stitch it all around. A continuous suture.
With continuous.
With continuous suture. And use a Cabral's operation whereby you use a 8 millimeter or 10 millimeter graft to the left coronary anastomosis, right coronary, same way you anastomose above the graft. Subcoronary implantation. So coronaries become above the valve. Graft is below that. There will be a small space between the graft and the annulus. Doesn't matter.
Thank you.
A new endovascular device is there. That's not available in India. Basically, that's being used in Europe. MFM. That is for dissection as well as the aneurysm. That is a just spring-like structure which we put in the aorta, and with that, all branches and everything gets saved. Even the aneurysm slowly gets thrombosed. So that is technology. Basically, it's costing around 15 lakhs. But whenever we try to get it, it's not available at that time. But in the conferences, that is being shown. I think that will be for where this endovascular can't be done or some hybrid has to be done. That may have the very good in that way, safe and effective. MFM, flow modulator. Using uncovered stent. Yeah, no, it's a big type, but its flow is so laminar that it maintains the branches and so it will be for dissection as well as thrombus. But in India, if we start making it with IIT and other things, then it will be at low cost, same as endovascular, between 5 to 6 lakhs. So it will be very good.
True, yeah. So we declare this session closed and request the test to. Yeah.
Thank you, Santosh sir, for that wonderful presentation and this informative session by the chairpersons. Thank you, chairpersons. I request Dr. William Bhatti sir, Dr. Alan Joseph sir, and Dr. Bashi sir to please come forward and felicitate the guest speaker, Dr. Santosh Matthew, the shawl and memento. Moving on to the next session of the day, Surgical Management of Small Aortic Root by Dr. Rajiv Kumar Gupta. I request the chairpersons to please come forward for the session. Dr. Ashwini Suri, Consultant Cardiac Surgeon, Tagore Hospital and Heart Care Center, Jalandhar. A round of applause, please. Thank you. Dr. Sunil Sample, Consultant Cardiovascular Surgeon, Mohandai Oswal Hospital. Please welcome them with a round of applause. Dr. Rajiv Kumar Gupta is a professor and head of Department of Cardiothoracic and Vascular Surgery at Hero Heart Institute and Dayanand Medical College, Ludhiana. He did his MBBS and MS General Surgery from Dayanand Medical College and Hospital, Ludhiana, and MCH in Cardiothoracic and Vascular Surgery from Christian Medical College, Vellore. He is an alumnus of CMC and has worked as a lecturer in the Department of Cardiothoracic and Vascular Surgery at CMC Vellore from 1996 to 1998, and as a reader in the Department of CTVS at Christian Medical College and Hospital, Ludhiana from 2004 to 2009. He is a life member of the Northern Association of Surgeons of India and Secretary of the North Zone Association of Cardiothoracic and Vascular Surgeons. He has supervised various research articles and has 18 publications in various national and international journals. He has operated around 800 children under National Rural Health Mission and is also working with various NGOs for treatment of poor patients. He is also looking after Saksham, Punjab chapter. It's an initiative for the treatment and prevention of various disabilities. He has an expertise in total arterial revascularization, ECMO, management of patients with cardiac failure. I hereby invite him for a presentation, Surgical Management of Small Aortic Root. Dr. Rajiv Kumar Gupta.
Very warm greetings to the distinguished gathering. It's a great feeling that after 20 years, I'm standing on this dais. I was part of this prestigious institution, and what I feel is that one cannot take CMC away from me, because I was in CMC Vellore. I was here, and firstly, I bow my head in reverence to Professor EGGLESTON, because when I joined CMC Ludhiana here, I was very nervous. I was very confused. But visiting a surgical lab, which was established by Sir Professor EGGLESTON, I got sort of an energy that to do something here. And I must thank Mr. Vincent Baldev, late Mr. William, and Mr. Jairus, who helped me day and night. What I say that I was very anxious at that time, and they tolerated me well. Thank you very much. So whatever I achieved, this place has contributed a lot. Whatever little success I've got in my career, I owe to CMC. So, to discuss this issue, management of a small aortic root, it's my dilemma or rest of my colleagues will agree with me whether this is a dilemma or not. Because aim of aortic valve replacement is to reduce the pressure and volume overload on the left ventricle. The presence of small aortic annulus, it represents a very clinical challenge in patients who require prosthetic aortic valve. And because small valve will increase the mortality, ischemic cardiovascular event, and stroke subsequently. Now, what we talk about post-operative patient prosthetic mismatch, if its peak gradient is more than 30 millimeter of mercury across the valve, or if gradient increases during exercise, then we say that that the patient is in trouble. If we take an indexed effective orifice area, they say it's less than 0.85 centimeters square. When we say that valve is narrow, but 0.65, again, some people accept. So what is small aortic annulus? There is no clear consensus. There are multiple definitions which are being used. Sometimes the valves which we use, the manufacturers, they put a label on that valve, and there are sizes, different sizes are available. So there is no uniformity in them. There is a ISO organization which says that the size of the valve is equal to the tissue annular diameter. So, in fact, in surgical series, a small aortic root is defined as an annulus that would not accommodate a prosthesis size of more than 21 millimeter. And by echo, if the size is less than 23 millimeter, then we say it's a small aortic root. And Asian populations, we have a small stature. A lot of literature is from Western world, and they have compared, as compared to the European counterparts, this is the findings, that we have average sizes close to 21 millimeter. So what are the characteristics of patients? There are strong female sex preponderance, obesity, type 2 diabetes mellitus, atrial fibrillation, and chronic renal failure. So in our practice, I think Dr. Bashi sir will also agree that around about 80 to 90% of the patients, they receive either 19 or 21 millimeter of prosthesis. And in our experience, I've done around about 27 cases where I have to put a small aortic valve. The age ranges from 14 years till 72 years. There is female preponderance, as we see that out of 27 patients, 24 were females, and majority were in New York Heart Classification 4. Only few of the patients which I did have less than 30% ejection fraction. Most of the patients have a bicuspid aortic valve, and only 6 patients have a mixed lesion where aortic regurgitation was also present. Our body surface area, they were lower, it's close to 1.5. So how we assess the aortic annulus dimensions? There are various modalities which are available. Now, cardiac computed tomography, MRI, 3D and 2D echo, which are helpful in assessment of the aortic annulus dimensions. If we go by this picture, if we see the aortic valve is a crown-shaped structure, there is a surgical ring, which is ventriculo-aortic junction, where we fix the valve, and there is a virtual ring where there is a nadir of the 3 cusps where we take the measurement. In TAVI, nowadays, like it's very important that in TAVI, they measure the size of the valve at the nadir of the 3 cusps. So that is on the B is showing that echocardiography at various levels where do the cuts, and C is again CT tomography, where we take different cuts, and D is again in the theater we do the transesophageal echocardiography. So this is one of the patients which we operated, and if you see the aortoangiogram, very small aortic annulus is there, and aortic root is little bit dilated. So this is a pre-op T which we took in the theater, and that's where we take measure the sizes of the aortic root at the LVOT junction, at the aortic annulus, and at the sinotubular junction. So this is just to refresh. This is the anatomy of the aortic root, where we can see the aortic valve, which consists of 3 leaflets only, and aortic root components are sinus of Valsalva, interleaflet triangles, sinotubular junction, leaflet attachments, and leaflet annulus. So why enlarge aortic root? To prevent a patient prosthesis mismatch, to prevent residual gradients, and to avoid progressive LV dysfunction and hemolysis. So what are the options which are available for small aortic root? Either you enlarge the root, use homografts or stentlets, xenografts. You can posteriorly enlarge the aortic root with Nix technique and Menugian technique. Anteriorly, aortic root enlargement, you can use a Rastan-Kono procedure or Kono-Ross procedure, or you can use a pico-aortic conduit. So this is the technique which is Nix procedure. Here you extend your aortotomy towards the aortic annulus from the middle of the non-coronary cusp. You extend across the mitral annulus into the body of anterior mitral leaflet and put a broad patch, V-shaped dacron patch, and it enlarges the annulus by 1 or 2 size. You can use this technique. This is what we are showing. We are cutting the aortic leaflet up to the anterior mitral leaflet, and putting a dacron patch, V-shaped dacron patch, and putting a valve. So then we can go for Menugian technique, where we cut between the left coronary commissure and non-coronary commissure, thus dividing the annulus. We can go up to the anterior mitral leaflet, or in really small roots, we can use as a Y incision. We can go towards the right side or towards the left side. So we used again a dacron patch, and we suture it. So I'll show you. This is again upper is showing Nix technique, and then we are cutting through the commissure, which is Nix Nunes technique or Menugian technique. So again, this is representative of putting a patch and suturing a valve over it. So this is the final picture. So I'm sharing my experience in 68-year-old female, where I have to enlarge the root, because echo showed a aortic valve area of 0.5 centimeter square, and I could only place 17 millimeter aortic valve. This is earlier I showed that this is a aortogram where the annulus size which we made was 15 millimeter, close to 15 millimeter, and the smallest size which is now available is 16 millimeter. So I have to enlarge the root. So this is a T from the same patient, very thickened valve and very small annulus size. This is at various levels. Previously I showed you that we measure the distances. So this is the what I'm saying, that Y incision. You go through the commissure, cut the aortic annulus, go up to the anterior mitral leaflet, and to further enlarge, you go on the right side as well as on the left side. On the right side, you can go quite far, which is supposed to be the non-coronary cusp, but on the left side, be careful of the left coronary ostia. After putting a patch, inside I used bovine pericardium, and outside I used Dacron patch, and that combination of patch, I fixed it and put a valve. Only 17, still after enlarging the root, this way only I could put a 17 valve. So post-operative echo, there was no AR, and still there was a mild stenosis. I can say there's a 20 millimeter of peak gradient, and with mean gradient of 9 millimeter of mercury. Another case where 32 years old female presented with dyspnea. Again, valve area was 0.4 centimeter square, and here, after enlarging that root, I could easily put 19 millimeter valve. So again, in this patient, I didn't go for a Y incision. I just cut through the commissure up to the aortic annulus, and I could put a bovine pericardium patch, suture that patch, and I was able to replace it with 19 millimeter valve. So again, showing that sutures being taken. Now, one thing to remember is that on the left coronary cusp and right coronary cusp, I take subvalvular sutures, fix the valve first, and on the non-coronary cusp, that annulus comes on the little bit on the higher side. Those sutures I take from outside and take out from the valve ring, and then you close that area. So here again putting a valve. So post-operative echo showed no AR and peak gradient of 22 millimeter of mercury. Now, Nix procedure we have used in 3 patients, posterior enlargement in 24, and Y incision, which I have to use because aortic root was really very small in 2 patients. Usually we use bovine pericardium as the inner layer, and Dacron on the outside to strengthen that bovine pericardium. In 3 patients, I used autologous pericardium, glutathione treated. So other procedures which we did along was MV repair in 1 patient. 5 patients required a double valve replacement. 4 patients required CABG. Bypass time was close to 150 minutes, and the aortic cross clamp time was close to 114 minutes. There was no mortality. Reoperation for bleeding, 3 patients required reoperation for bleeding. There was some small stitch that was where we have to take. 1 patient had acute MI on the table. I'll discuss that. 1 patient required permanent pacemaker. There was 1 early death in patient. This was actually a first patient who had also a mitral valve replacement. So follow-up echo, we could assess that there is an increase in effective orifice area from 0.7 to 1.2 centimeter square. In 6 months, there was regression of the LV hypertrophy. I took the posterior wall as a marker to see whether the thickness regressed or not. I think 1 to 2 millimeter of thickness, it was regressed. There was no perivalvular leak or mitral regurgitation in these patients. So the patient who had a myocardial infarction, I put a 18, there was a small root, and I put a 18 millimeter ATS valve because I thought it's better than 17, but it blocked the left coronary ostia because sinus was not effaced. So while replacing the valve, one must take care that left coronary ostia, right coronary ostia should be away. It should be lifted up by at least 15 millimeter, because in TAVI also they find these problems. And at that time we have to explant the valve and enlarge the root to accommodate 80 millimeter valve. Small aortic root poses a difficult problem to the surgeon. It should be performed in the patient having small aortic annulus to prevent PPM and post-operative residual gradients. Posterior root enlargement technique is the preferred choice and is quite safe. It produces good results and it enlarges the annulus for larger aortic valve to fit in. Thank you. Thank you for your kind attention.
Thank you, Dr. Rajiv, for the nice presentation and of a very controversial and a difficult topic. House is open for discussion. Any questions, please? Yeah.
Dr. Rajiv, excellent presentation, and it's a very dilemma situation because whatever tests you do beforehand or before going in for surgery, it is on the table decision most of the times that there is a mismatch, whatever valve we have planned size, it is not coming because of the small aortic root. It is very well if you can investigate it earlier and fix up that thing that we will be going in with a root enlargement. But most of the time we find it's on table that you have to take a decision and then think about this. But anyway, 27 cases have been done and the results have been good. And then we are sometimes think about that top hat valve or that is a supra-annular fixation of the valve. There are also options in our armament, but most of the time we are not prepared for that. But anyway, very good series, nicely presented.
Thank you.
Dr. Bashi, I read once you had given a statement in CSI. You remember that, I suppose?
Congratulations for a nice presentation and good series, very good results. See, aortic root, of course, as you also mentioned in your talk about the size disparity between our patients and Western population is different. There are 2-3 types of patients with aortic stenosis we have to deal. One is patients coming, in the pediatric group, in the middle age group, and the older age group. My conception is that if somebody has, for example, a 65-year-old lady comes with a small annulus, I may not be that aggressive in widening that root because she has lived with 65 years with a narrow annulus and comes with a severe aortic stenosis. So any valve we put inside will not be small than what she has. And she is not going to for a 100 meters race or anything.
Yeah, that's right.
Okay, yeah. That is. Secondly, to widen to get a really good annular enlargement, the best is the Kono technique, which usually in adults you cannot do because the right ventricle is friable. But now that Bong's technique, that is the posterior enlargement with the T-shape, that is a very good technique, very simple. Actually, you can see that video last 1 year ago only it was,
it's on the CTS net.
Yeah, CTS net, and last week there was a symposium, I don't know whether anybody has seen that, from CTS net there was a big symposium on small aortic root where the management of small aortic root was a very good talk actually. So that, I have done a few of this after seeing the video. In the first case I have to do on the table. We brought the video and because the patient, their aortic root was mentioned as 21 millimeter. When I opened, I could not put even a 16 size only I could pass. So we brought the video. Looking at the video I could put a 19 valve, 21 valve. Actually 5 sizes you can increase with the Bong's technique. It's very simple, vertical incision as you said, and go up to the right and go almost a little away from the left main and put a Dacron patch. 3 sizes minimum you can increase. The other problem with the Manogan technique, even that is good, because you enter the mitral anterior cusp, long time it is not good in younger patients because it can interfere with the mitral valve function, can produce mitral valve incompetence. Since I would recommend because of this technique has come, which is very simple, and earlier I was not that aggressive in advising aortic root. But after I saw this technique, maybe in a patient who is obese, even in older patient, if you are used to doing it, it's a good. But otherwise, earlier on the morbidity and the bleeding problems were much high, but now with all the good grafts and good suture techniques, and this technique is very simple. I think all of you should see that video. I mean, you will definitely like to do it. It's very easy to do. Only thing is when you take that posterior annular sutures, you have to be careful, make closer sutures, maybe put some glue or something. Number one. Number two is, when you are putting a mechanical valve, sometimes the disc orientation, because you are putting one slightly higher on the non-coronary cusp, the disc may get stuck on that area, because you are creating a new annulus with a patch. The disc can hit the patch.
Yeah, that's right.
It can impair the movement of the disc. So make sure you rotate the valve in such a way that the disc is, when you put a tissue valve, that's not a problem.
As far as the coronary impingement is concerned, first of all, like in bicuspid aortic valves, often whatever size is given to us on echocardiography, we find much lower than that size. If it is given 22, maybe we are able to put in a 19 millimeter valve, especially in bicuspid aortic valve. And secondly, regarding impingement of coronary artery, I have seen that maybe if we keep the struts in a far away position as from the coronaries, if they are not impinging upon the coronaries, the coronary blockage incidence is much less. And if at all, if there is a coronary obstruction, what we do is we don't explant the valve. We just put a graft onto the coronary. We just put a graft because most of the time the ladies are so fragile, annulus is so friable. I mean, it is difficult to take all the sutures out and then put the 18 or 16 or 15 sutures again. One is worried that sutures may start cutting through. So what I do is, I mean, one of my patients of double valve replacement with right coronary graft 17 years back. She is coming to me in a good condition, and another 3 or 4 patients, they are doing well. It is better, I mean, most of the patients are aged patients. In young patient, I can take it like you can put a bigger valve, or maybe if it is left coronary impingement, we can give a mammary artery. Even in dissection aorta, if we are unable to do anything, we can graft individually to the individual arteries, and that is also good enough.
I agree with you what you have said and what sir has said. That last 2 patients which we did, that Y technique, cutting towards the right side and towards the left side, that's why I was able to put a 17 in that, which I showed the aortogram. As far as that explanted valve, maybe that was an earlier experience. We were very confused that we were not able to come off bypass, and the heart was just still. So I thought I opened it up again, and then I saw that if I do the aortic root enlargement, and then we
actually
came
the
off.
surgeon is the best judge.
And another thing, like you said, that old patient, in 3 patients, sir, I have to do a Nix procedure. Because as soon as I try to fix the valve in after taking the sutures, the aorta got torn. So one has to be...
In fragile old patients with smaller body surface area, I have a very good experience about 16 and 17 millimeter valves. Any other question, please?
Congratulations, Dr. Rajiv, for this very good series of
Thank you.
small aortic root. This is a big issue. Slowly, aortic valve is slipping away from our hands. And TAVI has really taken over, and it is done, now previously they said that it is for old people who are not suitable for surgical aortic valve replacement. But then the indications became broader. Now it has come to a state that any aortic stenosis, they will offer for TAVI. And results have not been very bad. So it is, for us, a calcified aortic annulus is a nightmare. Actually, you keep on removing the calcium, you are bothered about whether you have enough tissue to, to place the sutures, and then about the heart block issues. And I had recently we had an issue with a case that was in UAE. One surgeon in another hospital, he has implanted in a Palestinian patient a 19 millimeter aortic valve. And this patient unfortunately had a post-operative some hemolysis, and then it has gone to a higher committee, and this patient was seen by another surgeon, and he said that this valve is too small. He should have put for his size, he's a 70 kilo man, should have at least put a 23 millimeter valve. But as surgeons, we all know that sometimes we have to, instead of, although root widening is okay, but definitely it adds to the procedure, and many times we compromise with 19 or maybe 21, something like that. And so then, in the case, so I was called to give an opinion. Then I was searching through all the literature, and then I found the Kirkland, the latest edition of Kirkland, in the small aortic root. What Kirkland has written is that it is highly controversial about PPM. And so small aortic valve may not be that big a crime, to be put. And safely patient has to come out instead of having too many complications. Invariably, all our valves, cardiologist will pick up gradient. And I don't think that after a prosthetic valve replacement, there will be no patient without gradient unless...
I know, I mean...
I also would like to add a comment. Simpler thing is to tilt the disc. So I have done tilting the disc so that you can put a larger valve, tilt it towards the non-coronary, so that the flow to the coronaries you can have, and you get a bigger valve. Like Rajiv has done, I think it's a good series, but like Santosh said, you are always facing morbidity. You are going to play with the patient's life and give higher risk. So if you are having good series, bigger series, then it's good. But in a smaller center, I would go for, like say, a 19 St. Jude Regent with a flex cuff. Now a flex cuff is available which has got a smaller sewing ring, and a 19 St. Jude can give a 20 size orifice. So that also is an option.
Yeah, regarding the gradient across the prosthetic valve, in my personal experience also, there are a lot of patients. I would say at least 15, 20 patients. One patient I operated 25 years ago. I put a 20 Yorkshire, this Medtronic valve. I knew she was about 75 kg. I tried my level best to put a 21 valve. A 21 valve I could not put. I put a 20 Medtronic valve, and then the gradient was about 90 millimeters. And after 6 months onwards, cardiologist was advising reoperation. She is from Orissa. She died after 24 years with 90 millimeter gradient. So many I have got. And if you analyze the history of patients coming with aortic stenosis, even without a prosthetic valve, you see, patients may be having 100 millimeters, 110 millimeters. If you ask the history, at least about 50% of them may not have much symptoms, especially in older people. Younger also, I have many patients, so I don't know, very difficult to correlate between the symptom and how do they get perfusion in the rest of the body with that stenosis is a question we cannot answer. Even though if you ask now the indications of replacement is becoming higher and higher because in lower gradient, because cardiologists are doing TAVI. It's like previously small ASD there was no need to close. Now everybody is closing even a PFO. That's an indication. So the feasibility of doing an intervention in aortic stenosis, what stage and when to reoperate a patient with a lot of patients I get referred from other places who had valve replacement with higher gradient, and very rarely I reoperate unless patient have severe symptoms on exertion, they cannot climb stairs or breathlessness or fainting. I don't reoperate. They are just being followed up only. So in a situation where you are not experienced in doing an aortic root replacement, a live dog is better than a dead lion. You send the patient alive, and any doubt, patient not coming off bypass with the ECG changes, close your eyes and put a graft to the LAD. Anterior wall of the heart, you put a graft. I had a very famous female singer, Tamil singer in Chennai about 20 years ago. She had a normal coronary arteries. She came for a joint replacement and referred to me. 160 gradient aortic valve. I did an aortic valve replacement. Brought the patient to the ICU. ECG change. Oh, no problem at all. I could implant the valve properly. All leads showing ECG changes. Took her coronary angiogram. Believe me, absolutely normal. I because I had only one theater, so I shifted. Other patient chest was open, so shifted the patient on the side room. I put her on bypass again, put 4 grafts, vein grafts. We did now she had a TAVI, 16 years later, we did a CT. All the grafts patent, vein grafts. Native coronary stone disease. I don't know how to explain it.
I must thank your comments, but I think it's where you get trained. Like you said, in Australia, I was there for 3 years in Australia with Professor Brian Buxton, and there I never saw any smaller valves. But when I was with Dr. Bala, there was very unique experience. Suddenly, where he has put 17 millimeter valve and where he has tried subcoronary implant for a stentless valve, suddenly a lot of patients that came with breathlessness and they were very symptomatic. And that time he told me to look into those cases. So I went through the echo, pre-op echos and all that. What I found was that where posterior wall thickness was more higher in like 15, 16 millimeter, they were the worst patient. They were doing much worse after a smaller valve. So I did my first valve here in CMC when at that time we didn't have many valve choices. There was Shri Chitra valve, and I put in a mitral position, and I was trying to fix it in a aortic position. I could not do it. So like you said that you saw the video, I bring in that surgical techniques that JTCBS I brought in the theater. And step by step, my first attempt was that where I just put a glutathione treated pericardial patch without a Dacron. After that, in all other patients, I started strengthening with Dacron patch.
Thank you, Dr. Rajiv. I think we are closing this session. Let us go on to the next session, please. Thank you.
Thank you. Thank you.
I request Dr. William Bhatti sir, Dr. Alan Joseph sir, and Dr. Bashi sir to please come and felicitate our speaker, Dr. Rajiv Gupta, with shawl and memento. Thank you, sir. Now, I would like to call upon the chairpersons for the next session, Dr. Rajneesh Carlton, Professor and Head, Department of Cardiology, CMC Ludhiana. Dr. Shahi, Professor, Department of Cardiology, CMC Ludhiana. Dr. Arvind Kohli, Senior Consultant, Government Medical College, Jammu. A round of applause, please. The topic for presentation will be acute coronary syndrome and cardiogenic shock paradigm shift by Dr. Yashpal Sharma. Dr. Yashpal Sharma is the Professor and Head of Department of Cardiology, Postgraduate Institute of Medical Education and Research, Chandigarh. He did his MBBS from Guru Nanak Dev University, Amritsar, MD from Rajendra Government Medical College, Patiala, and DM Cardiology from PGI, Chandigarh. He has an experience of 44 years in the field and has performed over 13,000 interventional procedures like angiographies, angioplasties, pacemaker insertion, carotid and renal vascular procedures, device closures of congenital heart defects, etc. He has around 180 national and international publications to his name and has written 8 chapters in various books. He has also received 18 national awards and honors. He has contributed in creation of COVID management protocols at PGI Chandigarh during the COVID pandemic. He is a member of various national and regional level committees, few of them being Fellow of Cardiological Society of India, Indian European Interventional Council, Indian Society of Cardiology, Indian Peace Nuclear War Prevention Association, and Association Physicians of India. I hereby request him to please come on the stage and deliver his presentation of acute coronary syndrome and cardiogenic shock paradigm shift. Dr. Yashpal Sharma, please.
respected chairpersons, Principal Professor William, Professor Vashi, all dignitaries, and dear students. In fact, I came last time also. I used to come here for DM as DM examiner. Basically, as I told last time also, my birthplace is very close to Ludhiana, that is Fagwada, GCT Mill. So at that time when I was studying here up to 5th class, and then this Brown Hospital was very important and everybody from Fagwada used to come there. And I went to Amritsar after this pre-medical. My many friends came here, and Dr. Navneet, who did a surgery and was a faculty here, he was with me at Amritsar, 1 year senior to me. So great memories, because our students, we used to come at that time also to CMC, because this was the closest medical college to Amritsar. And also used to buy some, when we were there, sweaters, and this one used to come in train in the morning and take from, because this was a place, Ludhiana, where jacket and other things were very, so medical students, they used to come to Ludhiana also for this purpose from Amritsar. So great memories. In fact, I was thinking that what to speak. Then, because this acute coronary syndrome and cardiogenic shock, this is one of the most important in cardiology for cardiologists as well as for cardiac surgeons, and is the leading cause of mortality. And you know that in India, they say that mortality is highest as compared to the Western countries. It is rather near double, and the interventions and other procedures are also not there. For cardiogenic shock, at one time, there was a lot of this, what to do. Mortality was at the tune of 80 to 90%. Some people were going for surgery, some unoperated, some otherwise. But in 2002-03, when we started working on cardiogenic shock, and some of the patients very sick took and did angioplasty, various IABP, in a very sick patient which were not operable with IC bleed, with PT. Then we started presenting those cases in the various conferences, staff clinical meeting, and in fact, the only question used to come, how you, I was presenting one case in Lahore International Conference, and the question came from the audience, how you could take this patient. I was really surprised because it was in the evening. I couldn't understand why this is there. So they said from the US that if we would have taken that patient, we would have sued, because insurance would not have given the money. Patient was too sick. This patient mortality is 100%. If you even saved. Then I thought that there may be some deficiency in the consent, and because of logistic, many things. But we kept on working on cardiogenic shock, earlier observational, this one. Later on, I gave planned thesis to the DM candidates. The first candidate started weeping, and he was not taking that thesis. He said, sir, I won't be able to do. How you say, there is no research, no this. I was really surprised. I told that you have to take the data, let's see whatsoever happens, what will be the result. If the mortality is high, you have to, this one. But lot of difficulty. 3 times he started weeping. He was from Hyderabad. And then when he did, and the results started coming, and it was really marvelous. And in 2011, Professor Peter came to PGI. He came to CMC Ludhiana because he was from South Kerala and settled there in USA since 1960. And he was very keen to visit PGI. So Professor Carlton rang me that he wants to come to PGI as a visiting professor. So I told him that please ask him to come on Wednesday, I'll be free. So for one day he was there. He saw cardiogenic patients in series, 4 or 5 patients surviving. VSR, severe cardiogenic shock, some on ventilator, some extubated, 4 patients. He asked the DM fellow, okay, how many patients do you get? He told that this is common. Then he told me, Dr. Yashpal, you should tell whole of the world that cardiogenic shock mortality is your least in the world. At that time, VSR survival was around 84 to 90% with interval VSR surgery and this very patient-specific precision treatment. So that was a great stimulus, and we kept on working on ACS registry and cardiogenic shock. So I will just this one tell some of our this data, as you know, as a theoretical plus some of our practical work thesis on the data of around more than 500 patients of cardiogenic shock and more of 3,000 this one ACS registry. As you know that, as I told that higher mortality in patients with ACS compared to Western countries, the 30-day mortality of STEMI 8.6% versus in Western 6%. STEMI constitutes more in India as compared to West. There are younger patients nowadays with COVID. More younger patients are coming with MI and shock because of hypercoagulable state. Same will be for dissection of aorta and otherwise also. After COVID, the number will increase. And there is a delay in hospital arrival in India. Door to fibrillation time is also more. They are less likely to receive revascularization, lack of STEMI programs, ECG facilities, ambulance services, financial constraints with PCI and use of thrombolytic agents. If you see the mortality, in pre-CCU era, that was 30%. In CCU era, that was 13 to 15%. And when this PTCA and perfusion and surgery came, the mortality became to the tune of 5 to 6.5%. But this was excluding patients of cardiogenic shock and comorbidities. That this is a published long back. This was our ACS registry from PGI, where we had 12,003 patients in 2018 and 19 with whatsoever sources. So because we have to decrease the mortality of these patients, if we were able to decrease, then only we thought that we will be able to decrease the mortality of ACS patients. And at that time, the mortality, this one, HP ACS registry, but no registry has done this one complete workup up to angiography, angioplasty, and follow-up. There are some registries which have taken data and just the mortality of that, but nothing of hospital up to the hospital discharge only. And those patients were discharged without any, just after giving the treatment, they were discharged. 30-day mortality, 1 month, 1 year, that data is not available of any registry. This was our paper with the delayed presentation of cardiogenic shock. In this, the mortality was 42.9%. The patient who presented late and were having all comorbidities. So this was published in one of the journal in recently, 2 years back, and the interior MI, renal dysfunction, mechanical complication, ventricular tachycardia, they were the mortality predictors. We kept on studying various parameters like cortisol, procalcitonin, and PTH. We were seeing what patients actually deteriorate, acute MR, VSR, cardiac rupture, very minutely. So in this, procalcitonin was found to be in a univariate analysis as a predictor of this. Because in patients with TLC counts higher and procalcitonin, the mortality was more. So if we give them potent antibiotic from the beginning and albumin, fluid, continuous monitoring, early, and these patients over 2 to 3 days, they become better. Rather than taking them immediately for angiography, angioplasty, if you stabilize, and if need be, you have to intervene early. Otherwise, in a strategic, innovative way, when they are done, majority of the patients, they survive. This is another registry which is going on. We also had this robotic angioplasty we started last year. Although we started in this process in 2016, So regarding this, it was very interesting for academic and research purposes so that precision angioplasty can be done. But I think with the time and result, this will be there, that robotic angioplasty become routine in the centers. Though its cost is higher, but when patent is off, the cost will come down and the many companies will start making it also. So otherwise the results are very good. We did it in ACS, also in chronic stable angina. The radiation is less, the time is less, and the fatigue is also less. Dye is also used less for the patient. Cardiogenic shock, as you know, STEMI, it's more with STEMI. It's associated with pump failure, acute MR, VSR, free wall rupture, usually 3 vessel disease, diabetes, traditionally associated with high mortality, recent improvement in outcomes 28 to 30%, but this is without comorbid diseases. The maximum predominant LV failure is the cause, then acute severe MR. Basically, earlier acute severe MR, when we started, the mortality was 75%, then it became 50%, then 25%. Now, with acute MR, mortality is same, rather only 1 to 2% higher, around 10 to 25%. Reason being, acute MR, if you treat them in a better way, hemodynamics, thrombolysis, then after that 2B3 inhibitors, for IABP in case it's needed, then they usually recover and after that do angioplasty. Otherwise, these patients were going for CABG plus this one multivessel grafting. So mortality in that was higher. So nowadays, they are given treatment for this one as well as multivessel stenting and left main stenting also. So that is also, for cardiac rupture, we couldn't save patients, but otherwise, for other VSR and acute MR, the mortality has decreased very significantly. This is just history. When shock was described long back in 1743, and the classification by Harrison in 1935, and Blalock, who was a surgeon, and basically William Herbertson described CAD as a disorder of the breast at that time. For more than a century, it was believed that CAD always caused death suddenly. The landmark paper by Herrick described clinical observation of patients in AMI with autopsy finding in 1912. The Pardy gave the ECG finding in MI in 20, and Fies et al. In 52 found evidence of reduced cardiac output in patients with AMI with shock. And Dewood in 1980 demonstrated that 85% of patients had coronary occlusion due to thrombus in early MI. So it was in 1980, it was found that MI is because of thrombus in the coronary artery. And very interesting, in COVID also, everybody was thinking that what is the cause of death, some cytokine storm or something. Basically, it was a coronary thrombosis that was causing VF and patients were falling. And it was really because of this cardiogenic shock when we were doing angioplasty, there used to be so much thrombus burden that whenever we used to open it, sometime earlier no reflow, and patient despite open this stenting used to die. Then we saw that this is wrong. We have to do something. We gave thrombolysis, after that gave 2B3 inhibitor, nicorandil, build up the patients, then took up for angio. Earlier we were using thrombus aspiration, but nowadays thrombus aspiration is also used rather 1 in 6 months, because thrombus burden gets lower, a modified dose of tirofiban is being given. So majority of the patient, almost 8 to 9 patients, they are surviving of cardiogenic shock out of 10. So that is a very interesting that if we could decrease the mortality of cardiogenic shock, the ACS mortality along with cardiogenic shock will decrease. Otherwise, all research which was being done earlier, cardiogenic shock and comorbidity patient, they were all excluded. They never were included in the registry. So revascularization, as I told that in cardiogenic shock with left main TBD, angioplasty used to be contraindication, class 3. Nowadays, it has become class 1A. because surgery was also not possible in many cases with acidosis, hypertension, patient on IABP or with pneumonia. So those patients with comorbidity, they were never taken for surgery also. When this was decided, it was Swan and there are 3 surgeons who decided that we will be taking patient of cardiac shock for surgery, but not all. They were selective. And the mortality because of comorbidities used to be high. As you know, Andrew Grudzik did angioplasty first. That was not for cardiac shock. It was long back when European people, this registry and all things came. Now they included this, started doing as a class 1A indication. This is our PGI experience. This LV failure is in 80%, acute MR around 9%, inferior RVMI 13%, and VSR in 1.1%. Determinants of mortality: higher age, previous MI CABG, oliguria, low GFR, altered mental status, high lactate levels, low ejection fraction, severe MR. This was in 2015. After that, we started working on renal, urine output, renal also, MR also, sepsis also. What we did that for renal, rather than doing multi-vessel angioplasty with normal dye, we started using very diluted dye. Visipac, around 10 ml, 10 to 20 ml dye. We used to make it 30, 40, and strategic, 1 or 2 vessel first. If they are critical, then only 3 vessel. Because in shock, when angioplasty started, it started that all vessels should be this one done, culprit and non-culprit. We were saying no, culprit in majority of the cases, non-culprit in some, and this total revascularization in few. And sometimes you have to do only non-culprit. Culprit you have to leave because LAD, which is thrombosed and patient has presented late, the LAD is non-viable. If we open it, patient will not have any benefit, rather than will deteriorate. He will go on ventilator. So only non-culprit also, and sometimes non-culprit first, culprit later on. So basically this is a patient-specific precision approach. This hard and fast guidelines can never apply. Just as CTO sometimes used to become chronic total occlusion. In cardiology, there was a dictum that CTO should be opened first. If it is not there, patient should go for surgery. Because stent cost was higher at that time, I don't know. But we were always from the beginning used to say, CTO at the last. First, any critical lesion, proximal LAD, wherever it is life-saving, do it. And in the next stage, open CTO. So CTO mortality was high. Retrograde, antegrade, so many approaches were there. And when we said that majority of the CTO will open by the antegrade approach only, so later on, the full revascularization used to be there. And these patients with poor LV, of the tune of thus 10 to 15%, 20%, also by building them up with iron, albumin, carnitine, and others, we would increase the ejection fraction to 25, 30, and strategic improvement from 10 to 40, 45, then we discharge. So survival also becomes immediate, 30 days, and overall survival becomes better. So this is our all cardiac shock patients, so decreasing mortality trend. And this during COVID, it was very interesting that our mortality of both COVID positive and negative patients, because there were no patients from the OPD or elective patients, all were emergency and they were very sick. And some of them were refused by surgeon also. Reason being, one was poor LV, patients were coming late, surgical theater also got closed because of anesthesia problem or other logistic patient sometime. So we have to do all those cases at that time. But fortunately, because our resources were all focused on that, very sick patient with 10% ejection fraction, this 2020, when second wave was going on. First wave, because first wave there was more of lockdown and all things. Second wave, lockdown were less, mortality was high. We could save those patients, and one of the patients, I just tell you that left main was totally calcified and it was a streaky. LED whole calcified, circumflex calcified, RCA cut off, ejection fraction 10%, and patient was on inotrope for 15 days, class 4. There were none of the option, but we saw the IVL. IVL became available in India at that time, and we did the first IVL in that case. And intravascular lithotripsy put this 5.5 left main stent and made it 3.5 in LED. On the table, ejection fraction improved from 10 to 35%. So that patient, similar other patients were there. So that was very interesting that during this time, our mortality was least 23.7% with all comorbidities. If you take the comorbidities out, then it will be around 15%. So with this, our total mortality also became 6 to 6.7%, include ACS with cardiac shock with comorbidities during COVID. So that was really interesting, and we published this. This is another registry where we are seeing this coronary involvement very minutely. This every artery where it is cut off, even small branch, and this we will be publishing soon. So mortality, primary PCI mortality is 4.7%. Our this facilitated, the primary PCI is rather very rare. Sometimes any surgeons, any cardiologist take, but with comorbidity, the chances of mortality in that remains high. If we are doing strategic pharmaco-invasive, innovative strategy, then mortality is around 2 to 3% of ACS. And also cardiac shock patients, they also survive. Contributing factor, as you know, the hypovolemia is a very important and most ignored factor causing hypotension. So judicious use of fluids should be done with IVC as a guide, urea creatinine, sodium potassium, and clinical status of the patient. Septic shock is very important to rule out. Counts of 10,000, 11,000 should not be taken as normal, especially when this COVID was there. Patients used to have 10,000 count. Otherwise, in viral infection, there is leukopenia. So this used to be a severe infection. The patient died of sepsis, cardiac patient died of sepsis. So when this immediately was shifted to potent antibiotics, all patients were surviving same as pre-COVID. So COVID and this one, hardly any now mortality difference. Then sometime over-diuresis also, associated severe valvular disease. Few patients were severe aortic stenosis, TVD, cardiac shock during that time. So we opened those valves, opened these arteries, then did TAVI, and there were very good results in those cardiac shock also. So in our series, all patients of cardiac shock are included irrespective of coexisting comorbidity, unlike most clinical trials where these patients are excluded, as I already told. Yet our outcomes are better than available published literature. So this is long back, 2015. Then hemoglobin. It's very interesting, there was a discussion going on. Hemoglobin is such an important factor. If even in the valvular disease, basically this innovation, this discovery of hemoglobin started from valve. I used to work on rheumatic heart disease first, and BMB intervention, because you know when you are junior, this one join, balloon mitral valvotomy and other things are done. Then you shift to this intervention otherwise. So we were seeing that mitral regurgitation, mitral stenosis, other patients, they used to have low hemoglobin and severe MR, MS. Some patients were not affording money, and we were waiting for surgery. Dr. Suri and in fact Dr. Gujral retired at that time, but he used to come to my office, and when these patients were given oral iron at that time, with this mitral regurgitation over 6 months used to decrease, and this severe moderate and patients used to become class 2, 1, and for 10 years these were on follow-up. So I did patent how this murmur gradient and clinical can change with just change in hemoglobin. As I think last time also told, the WHO and all books which has written hemoglobin 11 normal, that is a sample survey of one malnourished society or malnourished population done by SPM. Otherwise, hemoglobin is 14 to 16 in females and 15 to 17 in males. And in children, its value is still higher, 17, 18, 1 day, 1 month, if you see. So, if you increase the hemoglobin, MR decreases, ES gradient decreases, the murmur decreases. So, this is an eye-opener for everybody. In fact, Dr. Gujral, when he listened, he said, Dr. Yashpal, if you would have told me earlier, I would have given blood transfusion before rather than going for surgery. So it's very interesting, and he used to tell that Dr. Validan, Dr. Cherian, and Dr. Venugopal, all three were students, and he used to tell story of PGI when they were having training with him. So very interesting. So hemoglobin has a weight factor of 2.5 this risk score. Serum albumin low, less than 2.5 mortality. If you increase the ejection fraction and then do this one by just giving iron, increasing the serum albumin, building up, treating the sepsis, fluid, ejection fraction improves also, and the mortality also becomes less. This was our paper in 2011, 7 patients of VSR, and they were operated, 6 were operated, 1 was on medical treatment. They were operated from 8 days to 21 days, somewhere between. All 6 patients survived. 7 would have also survived, but that because of sepsis he died, and that was quite delay. One of the resident, because there was a label of some psychiatric problem on that, resident did a delay medicine that she is psychiatric when she was having some chest pain and VSR. So that was, so as I told you, this medical management stabilization is very, very important before taking any patient for intervention, whether this one stenting or surgery in a sick patient. So stabilization of hemodynamics, ventilation, intravascular volume, soda bicarb, anticoagulation, 2B3A, inotrope, antibiotic, IABP, thrombolysis, and PCI or surgery. Vasopressin, inotropes, nowadays norepinephrine is being preferred over others because that has a better, this one. This is also published in NEGM in 2016. IABP, beneficial in patients who have received fibrinolysis and are deteriorating, having tachycardia, rapid deterioration, shock, MR, VSR, high risk anatomy on CAG. This earlier our IABP use in cardiogenic shock was around 40 to 47%, but nowadays it is less, around 10%. We have used Impella and ECMO in anecdotal rare patient, but that has not made any difference. That is in high risk patient, PCI, we have used one Impella. Reperfusion therapy, just in that way, this was earlier that patient should be immediately taken to a center where PCI is there. But I tell you, patients should be thrombolized wherever immediately, whether it is a primary health center or any community center. If that is done, and then after stabilization, the patient is, the mortality of this ACS will decrease. Rather than 17 million patients dying annually, it will be a reduction of 60 to 70% mortality by this only. Because on the name of primary PCI, patients sometimes start from 200 kilometers in the ambulances, and even they are not given, they are just given aspirin only. So if all drugs are given and patient is stabilized, next day patient are this transferred or 2B3A given, the mortality will immediately come down. So strategic pharmacoinvasive strategy is very important. Even there are so many these agents, streptokinase, tenecteplase, retiplase, but in our experience we have seen that streptokinase is very effective and has a patency of 60 to 70%. IC bleed is not more as compared to others in all those, in all ACS patients. And no, IC bleed is rather less with streptokinase. It's a low cost. So after that, if there is a ST elevation is persisting, rather than this, if we start low dose terofeban modified decreased dose along with nicorandil and others, the ST settles and ejection fraction also improves because retrograde coronary starts perfusing. RCA starts giving collateral to the totally occluded LAD and the infarct expansion doesn't occur. Ejection fraction, rather than deteriorating, it starts improving. And if we give this, so that is a best strategy. In fact, earlier, some of the consultant and resident, they were afraid when they saw all patients surviving. Nowadays, said ejection fraction in 3-4 days, it's increased by 15-20%. So every procedure, when we taken in the cath lab, there is hardly any mortality of even any intervention nowadays in the cath lab. GP2BA, although there earlier we were using Efiximab and Eptipride, but terofeban, which in PGI is available around 700-800 rupees vial at a Amrit store by this, is giving so much benefit to the thousands of patients that all patients of ACS, they are surviving. This I have shown you, told you that our experience with terofeban is tremendous. Nowhere such amount of terofeban might have been used. Even for poor patients, it's given free because volume is there. Those who are not affording, they are given free or by this poor fund. We are probably the first center we started giving L-carnitine oral and also injectable nowadays in patients with poor LV and cardiogenic shock. After that, so many trials have come from meta-analysis from Mayo Clinic that it is useful. Though we have not published, but our documentation and everything is from the very beginning, 2000 onwards. Nicorandil also increases the coronary blood flow, small vessels, potassium channel opener, ischemic preconditioning, prevents arrhythmia also. Excellent response in ACH patient when given by intracoronary route in a modified dose according to the hemodynamics and blood pressure. It has a vital role in preventing post-MI arrhythmias also. This is this robotic angioplasty we are doing. This is just done from the control room and patient is inside. Usually if patient becomes sick, within 1 minute we can be with the patient just by removing that console cassette. But if patients are taken, then hardly any need be, because this does a very good work and precision is there and you are not having any radiation and tiredness is no there. This is primary PCI really superior? Nowadays, even in the Western countries, this question is raising again. This was in circulation 2017, because as I already told you, that patients with comorbidities or others are result-wise, the results are not better. Even wherever the best primary PCI in Europe or France or USA, the mortality is up to 5 to 8%. 4.7% is the least mortality. But so whenever one is applying any trial or any this one should always see what patients were excluded from this trial. If the patient with sepsis and others in shock trial and in other trial, they were excluded, they should be excluded here also when in practical term. What this mistake occurred in COVID, there used to be webinar all over the world in the first, and you know so many doctors, paramedicals, and this one lost their life along with so many patients. The mistake was that all patients were being taken for immediate intervention in the cath lab or further surgery. So when this was told that please do not do, always this one do thrombolysis, and there was not, from the Western country, This was not being agreed by, I think, stalwart of cardiology. They made a very arrogant comment, how it can be. It can't be, patient will die. I told them that it was a discussion on webinar, around 25,000 doctors were connected. I told that if you will say like this, you are seeing the result. So many patients are dying, so many doctors and paramedical. Go and see the Brown World and Hust. Was any patient with sepsis taken in primary PAMI trial? And that was last in that way. After 1 week of that, the mortality of 25% decreased to 5%. And now this one is less than 1%. COVID is same. Otherwise, those even who are not vaccinated, they are also getting COVID. But strategically, they are being managed. Of course, there are other sepsis and other management also become better. Role of diluted contrast, as I told you, that with 10 ml dye or zero contrast, just by IVUS or by marking, after angiogram, you can do the stenting. Culprit versus non-culprit, this I discussed. So unique challenges during COVID, I discussed. So ACS during COVID era was very challenging for everybody, but strategic this one always helped in this one saving number of patients. This was our patients, 600 out of 605 patients, 654 patients, there were 5.35 patients who were cardiac, and they were managed well, but some of the patients, because of we couldn't reach, the mortality was 14% of ACS and the cardiogenic shock, 24%. But otherwise, in Europe and others, it is around 41% 30-day mortality. So still the mortality, and during that albumin and hemoglobin, those who were having hemoglobin more than 12.5, the mortality was less. Those who were having 10.8, those patients died in COVID cardio MI. And of course, increasing age, low albumin, and low vitamin D3, high CRP, and high anti-pro-BNP. They were among those who lost their lives. So many COVID patient TLC count I already told. So our procedure strategy was able to achieve least mortality among these patients of 21% as compared to 42% in the other. Even the negative patients, I told that mortality of ACS was 4%. Earlier it was about 6.7% to 7.6% in pre-COVID era. And 25% of cardiogenic shock with comorbidity during COVID era. This option I have told that fibrinolysis, pharmacoinvasive, and innovative, after that starting of 2B3 inhibitors along with this innovative approach, and wherever judicious use of IVUS, OCT, FFR, QFR. So appropriately select and manage the patient before PCI treated comorbid disease like sepsis, hyperglycemia, anemia, judicious use of IABP in cardiac shock before or during PCI, use diluted contrast 2B3 inhibitors prior to PCI to reduce thrombus burden. Don't make a rule of treating culprit artery first or non-culprit, depending upon case to case and viability of the vessel and patient-specific approach, that should be done. This is our composite hybrid composite lab where CT plus this machine is installed last year, where we can do this various procedures and can diagnose dissection, PT, CTO, and TAVI and other procedures. So basically we have started using, and other applications are being applied slowly. This is our center. I humbly in that way tell that 2 weeks back we got this news that our center PGI has been selected as one of the best in the world, that by an international statista. So this was a good news for PGI, and I think as Professor Peter said 1 decade back, so his words became true. I was telling Professor Carlton, in fact I'll write to him that he said your center is best in the world, and this was I think he's not knowing, but I'll send this certificate to him that your words become true. Thank you.
Thank you, Professor Rajpal, for your excellent presentation and the extensive work done on acute coronary syndrome and cardiogenic shock treatment. Cardiogenic shock being one of the most serious conditions which occur in cardiovascular diseases. Mortality still remains very high, around 50%, even in Western figures. So there is a lot of interest in West to improve the management of cardiogenic shock. In 2019, actually, there has been SCAI shock classification has been given.
Yeah, ABCD.
Yeah, and they say it's a dynamic process, and between A to D. So have you been in your center using that?
Yeah, in fact, basically that is it, that you see the pre-shock. We as a very, this one, when the patient is having tachycardia and MR is there or something, we always say that it's a pre-shock. We never let that patient go into frank shock, because patient on inotrope and having controlled rate, then MR on NIV or something, basically they are in shock. The symptoms are increasing. So when frank shock is there, tachycardia is there, at that time need for IABP or hypotension. So basically you should be 24 hours attached to that patient by resident, this one monitoring, and evening, morning. Anytime patient deteriorating, that should be taken either for IUVP or for, but majority of the patient, 95% patient, they improve with the strategic, innovative medical and monitoring.
Right, sir. And as a lot of surgeons are here, basically surgical meet, like there is a heart team approach for the coronary artery disease.
For every this one heart team approach is taken, the patients are discussed with the surgeon, and wherever a surgeon or other that is a high risk for surgery, those patients are otherwise taken. And patient definitely, when pneumonia is there, some acidosis is there, at that time it's rather not advisable even to show to that patient to the surgeon.
Right, because there is a concept of cardiogenic shock team or some centers like cardiogenic shock hubs, and PGI being the premier institution in this area. Is there any sort of, you have a plan to have that type of center?
Yeah, we have planned this collaboration, national and international registries, so that whatsoever in that way, though we have published, but as I told you that when I went to US in 2011, and when we told about these results, it was really good for them. After that, the shock group, shock registries, because you know in those centers, the patients are not very high number. They have 2, 3, so they always collaborate. But the thing which was contraindicated for angioplasty now has become class 1A indication, and with this so much technology has evolved, Impella, LVAD, other things. So technology has advanced too much in that direction for shock nowadays. So hopefully this all over the world, the mortality will come down. Definitely when discussion in the conference is, basically it's not very, if you start treating 10 patients, you have a very good, this one. You see that all 10 patients surviving, 8 patients surviving, 7 patients surviving. But when we started this in 2001, 2, 1 or 2 patients were surviving. Then to 3, 4, observational. Then 4, 5. When 4, 5 started, then we gave the thesis. Then we planned study. Otherwise, nobody was even to take that data and show that in the this one, any conference that we have a 90% mortality, 80% mortality. So now this mortality is hardly 10-15%, and those who are elderly included in that, or with other comorbidities, those are also included.
Actually, your precision strategy has been there for some time, and it is being followed by others. But somehow we cannot get to reduplicate the fall in mortality so much by any means. Other centers, nobody has tried, got these figures.
The thing is, if by this same, we have it in the future, that the CCU and all gets connected by tele, and patients are given this. Even during this COVID, the various centers in Delhi, we were having tele, and those patients were surviving COVID positive. So at that time, the zeal was also there that everybody was asking for COVID. But nowadays, no, as you know, the doctors are so busy and they are always busy with their work. They never have now for tele again. So 25-30% tele and that practice should be there. Otherwise, I am telling in the south, west, east, even DM, wherever I go, whether here, Delhi, GV Pant, AIMS, the thing is, it is quite a shock. So many have even they have said that earlier this iron was not being this one. Now iron is being given in the West even with a normal hemoglobin. This red heart failure trial. So here it's being less used.
Professor Espol, I really enjoyed your talk. From a surgical point of view, I was thinking about 2 points. One is regarding the hemoglobin, second is regarding the albumin. Because we feel also in surgical cases, the low albumin definitely is high risk, especially when you do mitral valve cases with the tricuspid disease. Even my professor always used to say, and I also from my experience, one of the criteria we used to take, to decide to operate the patient with the severe tricuspid incompetence is the low albumin definitely is a negative indicator for mortality. I mean, it increases the mortality. Secondly, of course, in your experience also, low albumin is definitely an indicator of mortality. The other thing is about hemoglobin, because see, when average patient coming for surgery, the hemoglobin is around 12. We rarely find somebody 13 and 14. And during surgery, either is off pump or on pump, there is blood loss. So many of the surgeons, if you talk about blood transfusion, everybody thinks the transfusion is a crime. Biggest crime is to give blood to the patient. If you look about I was involved in a symposium where they say each time you give blood, your longevity is reduced, mortality is increased and all, which in practical experience we have never found from my experience of this. So many patients give so much of transfusion now, blood transfusion is so safe. And I also find when you, in a low hemoglobin, if you discharge the patient with 8 or 9 milligram, they always have breathlessness when they come back, diuretics is not. So I am also thinking whether, to improve the hemoglobin, give more blood before the patient is discharged, like make it about 12 or 13 milligram, the morbidity will be less. Have you done any studies? I think it is just worth looking into increasing, because as surgeons, everybody is drilled into the don't give blood. But I definitely don't believe in my unit. Most of the patients, whatever blood they lose, I give. Average about 2 to 3 units of another is off pump. We will use about 600 to 700 ml of blood. But there are some units which discharge the patient with 7 and 8 hemoglobin because of the fear of transfusing blood. So whether it is worth doing a study in patient, for example, we do bypass surgery and discharge the patient. A group, the hemoglobin is 10. A group where the hemoglobin you keep about 12 to 13. What is the morbidity of the patient? Just a thought of mine.
In fact, sir, as you said, rather than giving blood, it's IV iron carboxypolymaltose. If we give them 500, if it is less than even 1 gram stat, and subsequently next day, alternate day, and 3 gram, and hemoglobin increases by 3-4 gram. And that is definitely if we give either oral very high protein diet or IV albumin, because that depends on the severity. Because if we are giving only iron, hemoglobin doesn't rise. It is a iron plus porphyrin. So iron plus protein, if we are giving, then hemoglobin rises, and this rise is equivalent to the blood transfusion, near equal, 1 gram. With every injection.
Aggressive, and especially patients with the morbidity, every day I give at least 1 or 2 units of plasma or even albumin. So their wound healing becomes fast, morbidity is less.
You see the response in the evening.
Yeah.
If you are done round in the morning, you see in the evening. In that patient, those who are lying, they start seeing towards you and start sitting and talking next day on oxygen, otherwise almost comatose.
So it's very interesting, your results are very good, and listening more often from you about iron and all that. I think it's more important in patients with low ejection fraction. The hemoglobin should be more than 10 or 11. and I keep their hemoglobin up, recovery is much more faster. But as sir has said, Bashi sir has said that there are surgeons who discharge the patient on 7 or 8. I don't think so. That's a very good strategy. From point of view of putting others down, that we don't use blood.
In fact, my views are even 10, 11 is just nothing. It should be normal. Basically, to have a racial discrimination, that in the West it should be 15 and in India it should be 10. It's all because of our mindset and poor diet intake and poor starting the medication. If we give medication, every hemoglobin improves. Every means if there is a thalassemia or something, that is 1 to 2%. If we have read in MBBS and all that hemoglobin is this, why in clinical we can say that 11 is normal? If our book in the MBBS says that normal hemoglobin is never used to pass any student, how we can pass any student if he is giving DVR on the basis of 10 hemoglobin and murmur? Because that will improve. He will not need, when you will give, the murmur will decrease, echo will decrease. So there will not be any need for DVR, or patient will be just one valve, or it can be on medical treatment, it can be delayed. So basically, it is not in that way. It is a pure science and it is a pure our mindset. It should be normal. Average is equal to average, normal is equal to normal. Average can never be normal. We should not say that such a vital things that average, we should pass it as normal. This one, we patented this also. In fact, this has been patented from India, because patent office, they have already issued patent. Because such, I'm not saying that it's a knowing mistake, it was an innocent mistake. That's what I told that Dr. Gujral and comments of so many people. One of the cardiac surgeon, Ashok Sharma, he didn't sleep for 3 days, New Zealand. He said, Yashpal, what you told, I'm not able to sleep. So there are basically some consciousness starts speaking from the inside.
Thank you and congratulations, Professor Yashpal, for this excellent presentation and the results. And I have, about acute coronary syndrome. This is one area where there is no controversy between surgeons and cardiologists, because no surgeon wants to operate on acute coronary syndrome. Although the guidelines are, the results doesn't make a difference if you just wait for 7 days. But practically what we find that even after 7 days, there is some myocardial edema and they get, some effusion. So everything settles. So as long as the patient is stable, I would like to, usually wait for. My question is about the culprit vessel and the non-culprit vessel. So, your policy is to do the culprit vessel and...
I couldn't show that our series. We did around 60% culprit, around 20% all vessels, and around 10% non-culprit only. Because LED was, whole of the myocardium was non-viable. We did GLS score and RRT, PET, this one. So there was non-viable. So at that time, because when we stable these patients for 3-4 days, they become very much better. We are able to do RRT also and GLS also. So GLS in the descendant found to be very useful. Its results are coming equivalent to redistribution. So viability, we published it in this, and we are having more data. So we have a very good, latest EPIC machine in CCU. So we do there only GLS as well as whatsoever, because maximum benefit is for the sick patient. For stable patients or others, everything can be there. Because mortality is of the cardiac shock.
In many cases, very enthusiastic and maverick cardiologists, they will start with saying that they will do the culprit vessel, but ultimately end up with, for doing everything, a complete job.
Yeah, if there is 99% all and that is simple, you have to in that all vessel. But earlier, if you know, we were the only to say that one majority of the cases we should do culprit. Earlier in cardiac shock, it was there that do all vessels. Listen. Now only 2018-19 culprit this one has come. Otherwise, earlier all were saying that you do all vessels. If you see the literature. And when we used to say culprit, majority of the vessels, nobody was agreeing at that time. But nowadays, it has become in the guideline.
Yeah, in our place, actually the deterrent factor is that if you happen to stent more than 3 stents, the insurance coverage is not there. And so you have to, if you have to put too many stents, it is better that you send for cabbage.
Definitely. Nowadays, the longer stent is also giving same result. We have getting a stent up to 48. So 3 stent, majority of the 2 stent only, sometimes 3, sometimes 4, 5, sometimes. Because if LV is very poor, has been refused by surgeon, and if patient is frail, 80, 90, then depending upon case to case, but not all. Strategically in staging.
Thank you. Thank you for the excellent results.
Thank you very much. And if there are no questions, we'll close this session. Thank you.
Thank you, sir, for that wonderful presentation. Thank you, chairpersons. I request Dr. William Bhatti, sir, Dr. Alan Joseph, sir, and Dr. Bashi, sir, to please come forward and felicitate the guest speaker, Dr. Yash Paul Sharma, with a shawl and memento. I request Dr. Vijay Kumar Sharma, Director, CTVS Ludhiana Mediways, Dr. Munish Das, Cardiac Surgeon, DDMM Heart Institute, Nadia, Gujarat, to chair the next session, Changing Paradigm of Aortic Valve Replacement Surgery by Dr. Satish Matthew. Please give them a round of applause. Dr. Satish Matthew. Dr. Satish Matthew is the Chief Cardiothoracic Surgeon at Kailash Group of Hospitals, Noida and NCR. He is our own alumnus of CMC. He has done his MBBS from Rural Medical College, Pune, MS General Surgery from Christian Medical College, Ludhiana. Following that, he has worked as a lecturer in the Department of General Surgery at CMC Ludhiana from 1995 to 1997. He then pursued his MCH in Cardiothoracic and Vascular Surgery from GB Pant Hospital, Delhi. He was the youngest independent cardiac surgeon in the NCR in 2006 at the age of 38 years. Over the last 18 years, he has performed over 5,000 independent cardiac surgeries at Kailash Heart Institute, Noida, with excellent results. He has performed various types of surgeries, many of them being done for the first time in Noida, like proximal aortic surgery with aortic valve repair in 2015, the Bentall operation in 2017, the ventricular septal rupture repair in 2019, cystisorb filtration surgery in 2020. He has around 10 publications in various national and international journals. He's a pioneer in off-pump CABG, robotic CABG, combined CABG, and valve procedures, proximal aortic surgeries like the Bentall operation. I request him to deliver his presentation on changing paradigm of aortic valve replacement surgery. Dr. Satish Matthew, please come.
Thank you for the introduction. And I also like to thank Alan, my friend, for the invite, Dr. William Bhatti, the present director, also my colleague during our residency days in general surgery. And of course, I know the driving force is Dr. Navneet Chaudhary, behind this Dr. Eggleston Memorial. So that's how we trace, or I trace, my surgical roots to Dr. Eggleston, because Navneet was there, he trained us, and I always remember him at double speed. He used to take rounds at double speed, and I used to be in all other units for a long time. I did only 4 months in Navneet's unit, and I used to admire the way he used to finish night rounds. Within 10 minutes, male ward and the female ward used to finish. And our rounds used to start in Ward 23, ICU, CCU, Patani, where all we used to go. And by the time it was 12 o'clock, Dr. Kim Maman used to tell, now do you want to have dinner or do you want to finish your ward work? At night, 12 o'clock. So that's how I equate with this institution. I learned my general surgery and, of course, so many other things. I learned from MD medicine doctor that you must palpate the patient, and she beat the cardiologist in our institution because he missed the dissection and she caught the dissection as a general medicine. So you must touch the patient and you must auscultate. You will catch the dissection, you will catch the VSR if you auscultate. So the question of, is the stethoscope redundant? No. We must use whatever skills we have been taught from our institutions as we go forward. So coming to today's topic, more of it is theory for me, as I don't do this procedure, which is the hidden agenda in this tower. And secondly, I know lunch is following, so I won't be long. So we know the aortic valve is on the left side between the ventricle and the aorta, permitting the blood to flow from the left ventricle as it is pumped out into the aorta and the systemic circulation. Rajiv and others have already told about the aortic root anatomy, and there are 3 rings to be remembered and 3 cusps. So the important rings, the virtual ring, as Rajiv already mentioned for TAVI, and the ventricular aortic or arterial ring a little above it, and finally the ST junction shown in red. In this space, the space known as the sinus of Valsalva, are 3 leaflets, 3 coronary cusps, and that delineates, or the anatomy or the nomenclature is given according to the coronary arteries which arise from it. So the one which gives rise to the right coronary, that is known as the right coronary cusp, and the left giving rise to the left coronary. So the one which does not give rise is simply called the non-coronary cusp. This knowledge of anatomy enables us to go ahead with the surgical procedure and planning. It's important to know, I always plan for surgery. Like some of the surgeons said, you must do it a day before and plan well so that you don't have a problem on the table. You must know, you must follow the echo yourself and see what is the annulus. Aortic annulus is important, so you know which valve you are going to fit in. Very rarely you will get a surprise on the table, and it is better to be well prepared in advance. So this is what we want to know from our echocardiographic friends about the aortic annulus. And this is the anatomy important now, not only for the surgery of AVR, but in TAVI also it comes into a very important role. We have to know that the bundle, the area shown in green, that's where the penetrating bundle of from the AV node goes into the ventricular septum between the right coronary and the non-coronary cusp. So the types of pathology, basically it is a stenotic lesion or regurgitant lesions. The stenotic ones are usually senile or degenerative, where calcium has deposited on the leaflets and narrowed it down. Once it becomes severe, less than 1 centimeter square, patients are grossly symptomatic. And the other cause is bicuspid, which is a congenital cause and usually presents by about the 4th decade of life. Rheumatic heart disease is the commonest in India, and infective endocarditis can also cause aortic stenosis. For aortic regurgitation, usually it's rheumatic, rarely degenerative and bicuspid. And of course, collagen disorders, like already Dr. Bashi has mentioned, Marfan syndrome and earlier the Danlos syndromes. For the pathology, this is how the bicuspid valve is. So there can be variations of this bicuspid valve. This is the anteroposterior variation. There can be unicuspid also. It is important to remember because TAVI is not recommended in this condition. What are the classic symptoms? The patients present with angina, syncope, dyspnea, fatigue, and palpitations. Why it is important to know? Once your patient presents with angina, he hardly has 5 years of average life left. If he has syncope, he has hardly 3 years of life. And if he has failure, then within 2 years, he is going to go. So you have to intervene, and that forms the reasoning for our surgery. The first surgery was done by Charles Hufnagel from Georgetown University in the US in 1954. Now this man was doing it in an experimental lab in dogs, and he implanted it in the descending thoracic aorta, not in the original position, because at that time there were no cardiopulmonary machines or heart-lung machines. And he first implanted it in a lady with rheumatic heart disease. She survived 10 years. So you can see that this is a chamber with a peanut-sized ball, plastic ball inside it, and once blood came through it, it would push the ball and move forward in a forward direction. If it tried to come back, the peanut plastic would come back and stop the leak back. But this was just a initial few cases. The next was by these two inventors. I call them geniuses because this particular valve we have all seen, and it's a master valve designed by Miles Lowell Edwards, who was an engineer basically in Portland, Oregon. And he had just designed the Boeing engine. The Boeing company in Seattle, they wanted, they were having a problem with the fuel injection into their planes which were flying about 30,000 feet. And at that time, at that height, altitude, and the pressure, fuel was separating into gas and into liquid form, and it was not being able to pump into the engine. So they looked towards Edwards, and he designed a centrifugal pump which threw out the gas and took in the liquid, and therefore planes could fly about 30,000 feet. So this man had just retired, and Albert Starr, who was 30 years at that time, approached him, and they designed this fantastic valve. For many years, we've used it for 70 years odd, the ball and cage design. It was the model 6120 which took up most of our careers, and it's made of a stainless steel cage. Inside this is a silastic ball which moves just like a soda bottle. In the earlier days, we used to have that ball in the middle, and it used to allow the blood to flow through the cage. The other design after this ball and cage design were the single disc. Classic of this is the Medtronic Hall, and then the bi-leaflet carbon which we have been using now and current generation. It's coated with, it's a titanium metal with carbon pyrrolite coating to prevent thrombogenesis. So this is a better view of how the single disc used to. It used to have a major orifice and a minor orifice, but it also fell out in vogue because of the incidence of thrombosis and gave way to the bi-leaflet valve, which has got lesser incidence of thrombosis. All these valves are metallic, and they have to be anticoagulated. So the patient has to have another problem, that he has to keep checking the PT-INR and how much is to anticoagulate and come in the OPD repeatedly. So somebody has then progressed with the next generation or next design of valve, starting with the tissue valves. So these tissue valves were initially from either porcine or bovine source, and they had a shorter life, 5 to 8 years. Then they started thinking, let's prolong the life of these valves and why lose our patients. So they started doing anti-calcium therapy when they found that these valves were degenerating because of calcium deposition. And then nowadays we have thermofix and zero pressure fixation, so they have advanced. And this is on the top right-hand corner, the classic Paramount Magna Ease, which we have been using for so many years, I think 20 years now. And it has given way now to the Avalis bioprocesses or the Inspiris Resilia, in which this, the scaffolding is such that you can put a valve inside another valve. Because these valves may last only 10 to 15 years, so if at the time patient is say 80 years, he can go in for a redo procedure in the form of a TAVI, instead of having a redo aortic valve replacement surgically done. In the middle is the freestyle aortic root bioprocesses. Some of us have seen this, but it is a more formidable procedure where the cylinder of the porcine valve is put inside the aorta and sutured in place of the native aortic valve. So the newer prosthetic valves, this is the MyValve processes available in the Indian company and from Gujarat. The original one were the Edward Sapien, and the next to it is the newer generation model. These are bovine pericardium, and the other one is the Medtronic core valve, which is a self-expanding porcine pericardium valve. So I already talked about aortic root replacement with the freestyle. I will not go into details because it's readily done. And the valve conduits, this is how the valve is fitted in. Either it can be sutured on the table, or it can be, it is available as a company fitted valve conduit, which is much easier to do. The other option is to use a tissue valve inside the graft. This also is company fitted, and otherwise can be done on the table. So after all these, somebody thought, why not have sutureless valves? So sutureless valve is a newer design. This needs only 3 sutures at the commissures, and it has to be crimped and fitted into this tube, and it can be done on the table and fired in position trans-aortic into the valve at the annulus position. So we are familiar with the surgical aortic valve replacement done through a conventional stenotomy, and the results are like this. Many of you residents would have seen how Alan does a AVR. This is just like that. We have to suture the valve in situ after excising the diseased valve. But now we are changing slowly, and surgery is slowly, people are thinking that it's more invasive than what they would like to have. So we have to go in for more advanced therapy, and that's where minimally invasive has come in. And there are many different ways of doing a minimally invasive: upper hemistenotomy, J-shaped, lower hemistenotomy, or trans-stenotomy, or even through a right anterior thoracotomy. So many other incisions. The advantage is that they are cosmetic, have lesser blood loss, and shorter ICU stay. So they give very good cosmetic result, as you can see on the lower right side. And when I was in escorts, I presented a paper in Bangkok, and that's where we produced, we showed 30 odd patients in 2004, where we did 25 through the upper stenotomy and about 6 through the right anterior thoracotomy, and with good results. We had only 1 mortality at that time with infective endocarditis, but otherwise almost the same clamp time and good post-operative results. I'll just mention about aortic valve repair. I don't do these things, but just because it's there for everybody to know. It's a natural valve itself, so you don't need to anticoagulate, and it is more durable than the animal valve, which we have seen only about 5 to 15 years. The techniques are doing either you cut the commissure or thin the valve, which has got thickening, do a cusp extension or annuloplasty of the Duran or Carpentier technique, or a cusp resuspension. Nowadays, the Ozaki technique is being done in the mainly pediatric age group. There are templates available. The template itself is expensive, not freely available. You have to cut the pericardium. The patient's own pericardium is cut according to the BSA of the patient, and then sutured in position in the aortic leaflets after excising the diseased ones. So as Rajiv already mentioned, in case you have a large patient and you have a small annulus, we have to try and avoid fitting in a small aortic valve, because that will be detrimental to his outcome and reduce his NYHA function class. The heart will be overloaded. So to avoid it, we have to go in the green zone, that is stay above 0.85. That is the gold standard. So if one has a small aortic root, either you do a Ross procedure that is designed by Dr. Donald Ross. I have only seen this procedure done by my seniors, and it started in 1968, where he did he took out the whole cylinder of the aortic valve, which was diseased, and replaced it with the patient's own pulmonary valve in the position of the aortic valve. And in place of the pulmonary valve, you have to put in a homograft. Homograft is taken from a cadaver and it is cryopreserved in liquid nitrogen. You have to thaw it and then stitch it back in position of the pulmonary valve. This was an excellent operation, but it's a formidable operation. Like we talked about the root widening, this had got its own crux, that the septal artery or the LAD was just behind the pulmonary artery, used to get damaged, and then you could lose the patient on table. But otherwise, in the hands of experts, I would say super experts, that it gives good results, and those having experience with this gives at least 20-25 years. The only problem comes is the pulmonary homograft. You'll have to do some intervention somewhere down the line. Otherwise, rates of infection and thrombosis were very rare. The second operation, already Dr. Bashi has shown, and Dr. Santosh also has shown, designed by Dr. Bentall and De Bono, who were both from UK way back in 1968, where you replace the complete aorta of the ascending part and the root, remove the valve, and reimplant the coronaries as coronary buttons. So this is how it is done. You can do it for a small aortic root, but usually it's done like how Dr. Bashi and Santosh did for aneurysms or dissections. The patient's head end is down and the foot end is on top. So you can see this is the anesthetist view, what we call, and more and more surgeons are doing these procedures with good results. And this is how it looks at the end of the procedure. But again, they are very formidable operations for newcomers especially, and you end up trying to save the patient. Blood loss is a big detrimental factor, and this is just a gag that the income tax guys are after us. So now coming to why need all this anesthesia? Why need this heart-lung machine at all? And this man outthought many others. Professor Alain Tribier from France in 2002 did the first tower, and he was actually already doing balloon aortic valvotomies. And the surprising thing was he was persisting. He had 80% mortality, and he was still persisting. And he thought of this, and he combined with a company, biomedical engineering company, and designed this valve, which could be done transfemorally. So his first procedure was done way back in 2002. That's 20 years ago. So where are we standing? So as I mentioned already, the first Edwards valve, it was made of stainless steel. It was hard, and the device had to be put through the femoral artery. It was a big device. The steel would not bend, and it was difficult to implant. A 19 French femoral sheath would be put in, and therefore there were vascular complications related to that. Then it progressed to a second generation chromium cobalt valve, which was more pliable, and the third generation, it got an outer skirt of pericardium to prevent the paravalvular leak. I will tell more about the paravalvular leak. Along with it came the Medtronic valve, and this is the core valve and the new generation Evolute. These are not balloon expandable like how the Edwards valve is, and the core valve is self-expanding. So as you deploy it, it expands into its position. The common three routes of access are the femoral artery, the transapical, that is after you open the chest, or through the aorta. Rarely people are doing from other sources like the carotid and transaxillary also. Somebody has done through the side of the chest also. But coming to the trials, now the important thing is that we used to think as surgeons that it's not possible, the results won't be good. And initially the first trials came out in 2012 for TAVR with the high-risk cases. Those high-risk cases are the ones which surgeons think, no, we can't do it. there's a STS scoring which says 10 to 15% mortality risk. So they took up 2 surgeons and studied about, means you needed 2 surgeons to say, okay, this is a high-risk patient. And they took up about 1,058 cases, divided them into 2 groups, A and B. A was the high-risk patient with TAVR versus SAVR, randomized prospective trials in multi-centers. And the part B was in the TAVR versus the medical management. So in that, surprisingly, they found that the results were quite good, and 30-day mortality was 3.8 and in TAVR group, and the SAVR group was 6.5. And the 1-year mortality, of course, went up to 24% in the TAVR group and 25% odd in the SAVR group. I asked myself, why did they have such high mortality? But that's because they took up the patients who were 80 years plus, who had comorbid conditions. So they had other things to kill them. So anyway, the TAVR showed better results. So that's why they started doing it in the high-risk patients. And in extreme risk also, they found good results. That is the partner 1B. So partner stands for percutaneous aortic transcatheter valve studies, aortic valve replacement. And then came the intermediate risk, where they took up patients having a risk of, say, 3 to 5%. And there also they found that the TAVR was non-inferior to SAVR. And finally, what surprised all surgeons was the worst for us. It's the dread that the low-risk patients also having non-inferior results, in fact, superior results to surgery. So TAVR is going to come, my dear friends. We have to face it. And it will come more and more down the line. We have to be prepared for it. So this is the same thing which I mentioned, partner 1, 2, and 3 trials. 3 trials, long-term results are not out. They have completed 2 years, and they are expected to go for 8 years more before we know the full results. So for doing a TAVR, you have to be investigating your patient properly. And nowadays we are having very good CT scans, 64 plus slice, so they give excellent results. Rajiv has shown how to look at the aortic annulus, where your landing zone is, where will be the aortic, the coronary ostia. You must not implant the valve into the ostia, because you will develop complete block, and heart attack will happen on table. So you must plan it. It should be at least 8 to 10 millimeters above the annulus. Then the aortic annulus per se itself, it should be adequate, but TAVR is better for narrow aortic root also. The femoral arteries are important because if you approach from the femoral artery, the adequate size is important. It should be at least 8 to 10 millimeters. Now, current generation of TAVR deployment through the femoral artery is good for even 8 millimeters. And you can recreate the whole thing like this on the CT. So this is just a video animation of how the TAVR is done. So this is the calcific aortic valve, stenosed. And through the femoral artery, a wire is guided up into the descending aorta, arch, and into the across the aortic valve into the left ventricle. Then you have to dilate it or break it open. So once it's positioned, the balloon is opened and the valve is cracked open. That balloon is removed and followed by the actual valve itself. So this is the TAVI valve being pushed into place, and all this is done in the hybrid cath lab. The good thing is now exact positioning can be determined, and if you open it in the wrong place also, it can be retrieved. Previously it could not be done, but now retrieval and repositioning can be done. And then the whole system is taken out. Once your hardware is out, you can see the whole thing on the angio. But remember that the boundaries of this, the calcium has to be able to hold the valve. So it's difficult to put in a regurgitant lesion, not recommended. And this is how it looks on a synangio. As the balloon is being expanded, the valve is pushed into place. And that's how it looks when the balloon is removed. You can check it that it's not leaking, that there is no dye rushing into the left ventricle. And the other hardware that you see, the wire coming in, that's the pacing wire, because the rate has to be increased to about 200. Only then you can avoid LV ejection and displacement of the balloon and the tower valve when it is being deployed. So it's momentary, and that's how the lower picture shows the tower valve in place. So the biggest advantage is you don't need general anesthesia. There is no incision involved. The patients can go home within 1 to 3 days. There is a reduction in the all-cause mortality, CV mortality, and also repeat hospitalization. There is definite improvement in the mean gradient and valve area. NYHA function class improves, 6-minute walk test, and the quality of life also improves. But there are disadvantages too, and we must be aware of it. As one implants the tower valve or puts the balloon, there will be some dislodgement of calcium sometimes, and this can result in a stroke. There is a way of avoiding this also. I will come to it later. Valve dysfunction can happen, or paravalvular leak, which was the crux of the whole tower in the beginning. That paravalvular leak, even moderate, would cause higher morbidity and mortality. So they have come up with the new design I mentioned, that the skirting was reinforced with pericardium so that the paravalvular leak is prevented, and you have to wedge it nicely into the annulus. Vascular or bleeding complications, they have also reduced with the newer generation of tower valves. Annular rupture or LV perforation if it was mislodged, causing tamponade and urgent surgery. Acute myocardial infarction if the coronaries were obstructed. Thrombosis because of the blood clotting on the valve, infection, and death. So these are the known side effects. So to improve outcomes, there should be a tower heart team. Some discussion already has gone into that. Correct patient selection should be done, and the operator should be improving their skills every time. The improvement in the valve design and positioning will help. Judicious post-implant dilatation and subsequent device generations will help. The reduction in the sheath size will help in the femoral artery complications to reduce them, and the distal protection devices can be put in through either radial artery into the carotid to prevent the calcium stroke embolization. And finally, better standardization of the antiplatelet and anticoagulation therapy to prevent thrombosis, valve thrombosis. So in our time, we didn't know about this, and yes, we would have faced the same situation that is here. I know some of you may have faced it in other questions, but India is not far behind. Our Indian surgeons and cardiologists have already done this. Way back in 2010, the first tower was done through the apical route, and then there are other people who've done it through so many other routes, and so many other valves have been implanted. So tower is an alternative for aortic stenosis, even with a low surgical risk, as shown in the partner tree trial. But low surgical risk does not mean low age. For low age, you have to do SAVR. So it's only the low risk factor which is to be considered. And good diagnostic workup should be done. The surgical risk assessment will determine if TAVR is the appropriate course of the treatment. And we know now that TAVR results in good valve functioning and gives good hemodynamic effects, therefore will give good clinical improvement. So remember that 60, the new 80 is 60 years, and we have to think that the patients don't like being operated with such major surgeries. The morbidity is there with surgical procedures, and as a surgeon, I also have faced problems. If this procedure comes in vogue, it will be a game changer for patients. So it is going to come. Thank you.
Thank you, Satish. As usual, I worked with him for 2 years. He is an excellent surgeon as well as an excellent teacher. We should give big hand of applause and teacher. He covered the topic so well, you know. And I enjoyed his company at that time. I still enjoy sometimes talking to him. Your institute, people are very happy, students must be very happy that keep on visiting Ludhiana. I think you have come after so many years. Yeah. Thank you. Any questions?
Yeah. A very interesting talk and good results of Tower. But when we talk about valves, I think two persons we should not forget, Dr. Kalke and Dr. M.S. Valiathan. The bileaflet valve which we are using, Dr. Kalke, when he was working with Dr. Lillai, he has a great contribution. He came back to India, so initially his name was not there, but he was one of the pioneers in Dr. Lillai team who developed that valve. And of course, Shri Chitra valve, Dr. M.S. Valiathan did a great job, and I think in southern India, it's being used more frequently rather than in our part of northern part. And regarding Tower, yes, it's a good procedure, and I still say in high risk or moderately risk patients, but I've seen complications in our institutions, like last patient, LAD, left main nostril getting blocked. So it's very important that this thing, you can't, 8 millimeter, 10 millimeter, it will certainly block. And second, I've seen in one of the calcified valves, there was sort of a rupture annulus of valsalva. There was shunt from aorta to RV. One of the patients we have seen went to block. So there, it's not without complications. We have to be careful. Thank you.
So, Rajiv, there are many designs of valves. I just mentioned the three valves just to give an idea to students, because they don't know what we are talking of. What is this valve? So this is the design. There are many valves available, and yes, Indian scientists also have done, doctors have also done good results in AVR. And the second thing is that about the Tower, I was also shocked to see the results in low-risk patients. So that is surprising. And I always used to think nothing can replace the surgical AVR. I have seen people present TAVI valve mispositioned, malpositioned, blocking. I mean, it came out from the position and was lying in the ascending aorta. And the cardiologist went in and put another valve in that position, so that when he inflated the second valve, this was pushed to the periphery, and it was wedged. So, I mean, 15 to 18 lakhs for one TAVI valve, and you do two. Amazing. I was shocked. But it has happened. People are doing it.
Congratulations, Satish, for this excellent presentation. Now, you are on which side?
I was given the topic by Alan. He said, "Sir, we are having a aortic topic. I have not done a Tower, but it's interesting to know."
Yeah. Many surgeons, have started implanting this, started doing Tower, and actually surgeons have taught cardiologists, because when it started in Sharjah, we had in the government setup, started the first Tower, that was the core valve. So one surgeon used to come and, because cardiologists, it used to be implanted through the iliac vessels. Femoral was not, it was the device was too big. And then many of those patients, they were very, very old patients, morbid, that kind of patient. And many of them have developed heart blocks. That was a problem with the core valve. But with Edwards sapien valve, it became much better. We used to always wonder that we see during surgery, heavily calcified blocks, and this is just being pasted onto the wall. How this is going to be? And of course, there is some incidence of paravalvular leak. But if a surgical valve gets a paravalvular leak, cardiologists will say it is a big sin. And for the TAVR valve, it is not a big sin. So anyway, I think eventually this is going to be the future. I fully agree with you. And thank you for the good presentation.
Thank you.
I request Dr. William Bhatti, Dr. Alan Joseph, and Dr. Bashi to please come forward and felicitate the guest speaker, Dr. Satish Matthew, with the shawl and memento.
We now have the Dr. Forrest Carey Eggleston Best Postgraduate Resident Award. This is an annual award which is given to the best outgoing general surgery resident. I request our respected Director, Sir, Dr. William Bhatti, HOD Surgery, Dr. Parvez David Haq, Sir, and Medical Superintendent Dr. Alan Joseph, Sir, to please come on stage. This year, this most sought award is being awarded to Dr. Ankush Goyal for the term 2018 to 21. Let's give him a round of applause.
Now, I would like to invite Dr. Parvez David Haq, Organizing Secretary, Professor and Head, Department of General Surgery, to please come and deliver a vote of thanks.
A very good afternoon. I'm not going to speak much because I'm sure everybody is hungry. As we come to an end to this second FC Eggleston oration, this event has been waiting for a long time. I would like to thank all our esteemed guests and delegates who has spared their valuable and precious time. Thank you all. Particularly, I would like to thank our guest speaker, Professor Bashi Veludan, for sharing his experience on aortic surgery, and all the invited faculty for this great academic event. Big thank you to the FC Eggleston Trust in America and Ludhiana, particularly those who traveled from abroad, Dr. Catherine Whitcomb, who is the Executive Director, and to our members of the Ludhiana board, that is Dr. Navneet Chaudhary, Dr. Sirish, and Dr. Sidhu, who gave out their precious time, came and joined us today and this morning. A big thank you to you all. Your commitment to this cause of celebrating the legacy of Professor Eggleston is much appreciated. I would like to thank our Honorable Director, Dr. William Bhatti, with the Principal's Office. Thank you for all the support that you've given to us to organize this event. The GS Office, who's helped us prepare the auditorium and all the work which has gone. We'd like to thank Colonel Rafi Barnabas. And finally, to our postgraduate residents, the interns and medical students who participated yesterday in the workshop which was held for them, and today for the, making this a grand success. A big thank you. Hope to see you again next year. God bless.
Now, as we come to the end of this day, I request Dr. Bashi V. Velayudhan, our Chief Orator, to please come forward and present a memento to our Honorable Director, Dr. William Bhatti, sir. Now I request Dr. Bashi to present a memento to Dr. Alan Joseph, organizing chairman for the function. I request Dr. Bashi to present the next memento to Dr. Parvez David Huq, the organizing secretary for the oration.
Thank you, sir. I request the people in the auditorium to please stand for the national anthem.
शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय
Thank you so much, everybody. Now I request you to join us for lunch, which has been arranged in lawns near the blood bank. Thank you so much.